Good evening, colleagues. A very warm welcome to the 8th Heart Failure Masterclass. These are classes in which we learn from the master teachers of the country. They tell us how to deal with various cardiology problems, analyze them. They teach us hemodynamics, differential diagnosis, and the nuances of imaging and the treatment. So we all learn a lot from this. With this, may I invite Dr. Venugopal to please take this forward.
Thank you, Dr. Chopra. Thank you. Good evening to you all. We have a packed program today. This is the 8th edition of the Heart Failure Association of India Masterclass. The first topic will be given by Dr. Jimon, who is additional professor in Achuthamenon Center for Health Sciences, Sri Chitra Institute of Medical Sciences, Trivandrum. Dr. Jimon is a very well-known figure in the field of health statistics and epidemiology. So it'll be a pleasure to listen to him talking about Kaplan-Meier curves today. The case is being presented by Dr. Harjap Singh from SKM Srinagar, and the student panel, Dr. Shashank, Dr. Debashish, and Dr. Amish are from Shillong, Indira Gandhi Regional Institute of Medical Sciences, Shillong. So with this introduction, may I now invite Dr. Jimon to give us talk on Kaplan-Meier curves. And Dr. Jimon, please, I'm looking forward to your talk.
Thank you very much, sir. Good evening, everyone. It's a pleasure and privilege to be part of this master class. And thank you for inviting me. I'm sharing my screen. I hope you can all see my screen. Is it correct?
Yeah, you can see it. Can you just make it slideshow?
Full screen.
Full screen?
It's full screen.
Okay.
Hope all of you can hear. Can I start?
Yes, please.
Go ahead.
Right. So today, in the next 15 minutes or so, I'll be largely talking about Kaplan-Meier curves as part of the survival analysis. If
Doctor,
I ask you,
can you stop and reshare again? It is not full screen.
Still not full screen. Jimon, it is not full screen.
Not full screen.
Slides are on the left side, and main slide. There's a main slide.
I'm not sure what's happening. It's full screen for me.
Yeah, here it is.
Half screen.
Half screen.
Anyway, I think go ahead.
I think you can go ahead. Yeah, now we can see. Yeah. Now it has come.
Now it's fine.
Now it's fine.
Okay, right. Thank you very much. So if I ask you in general, what's the main cause of death? All of you would say that it's going to be cardiovascular diseases. But if you ask a statistician who's doing survival analysis, being alive is statistically the leading cause of death, because if you're not at risk, you're not going to die. So with that, I'm going to start the session. And in this session, largely, I'll touch upon time to event data, what we meant by censoring. We'll talk a little bit about survivor function and the Kaplan-Meier plot, and how do you do the statistical test difference between two curves. I will not be touching upon the hazard function or the hazard ratio, which is a relatively larger topic. So in survival analysis, in general, we speak about the primary interest is not whether an event occurs. The primary event is of interest is when it occurs. And that is where the primary outcome is time to event. If it is death, we call it as time to death. If it is, let's say, progression to cancer, we call it as time to progression to cancer, time to development of diabetes, time to recovery from diseases. All these, we collect information from either longitudinal cohort studies or clinical trials. And therefore, since we are dealing with the time to event data, this is also known as the survival data, because we are playing with the time to death if it in case of mortality. So what are the features of time to event data? As you all know that the time to event, when we are talking about, it's going to be a continuous variable starting from 0.0001 to whatever be the follow-up period. So you don't expect non-negative values in your outcome variable. And therefore, it has its own difficulties as well. If you see the plot here, normally, you would all agree that if it's a symmetrical distribution, we call it as normal distribution. That is the most appropriate case for statistical analysis. But time to event data are not normally distributed. It's mostly positively skewed. What does it mean? That if you take the mean value, it's going to be higher than the median and the mode value. Therefore, you don't do the parametric test, the traditional parametric test with time to event data. And it's not a good strategy to go for non-parametric test. So we go for something called semi-parametric test, and that's what we do it in time to event data, since it's not normally distributed. The event not usually observed for all the individuals during the study. Therefore, we censor the observation. So an observation is censored if an individual does not experience event during the study. Say, for example, if your follow-up period is 2 years and the average follow-up period is 2 years, and if there is no event happened, you censor the information at that point in time at 2 years. So censoring time means time from baseline or the randomization, in case of a randomized control trial, until the latest date at which the individual is known to be still alive and event-free. And that's the definition of the censoring time. So what are the issues? What are the ways that we censor? There is something called fixed censoring. And in the fixed censoring, what we do, the event has not occurred when the study has ended or the data analysis is performed. What does it mean? At the end of the study period, the follow-up period, the patient is alive. Lost to follow-up means individual has been lost to follow-up at some point in time. So you don't have the information after that lost to follow-up. And therefore, we call it as, again, censored during the study period, because we don't have any information for that individual after the last follow-up date. But in survival analysis, in the normal analysis, we need to ignore them because we don't have the follow-up, the complete follow-up data. But the advantage in survival analysis is that even we use that information. Survival analysis method makes use of the information even from the censored observation. We don't remove them. We analyze them utilize them in our data set. So the assumption here is that the censoring is non-informative. That is, if an individual is censored, his or her subsequent risk of the event of interest is unaffected. That's what we expect. That's what we assume by doing the censoring, by doing the Kaplan-Meier survival plot. Let me make it very simple for all of you. Let's look at an example for time to event data. So as you see in the slide, there are 20 individuals, IDs from 1 to 20. And the second column here says death, whether the event has happened. In this case, the event is death. 1 means the event happened, and 0 means event did not happen during the follow-up period. And the third column, what you see is the follow-up time. If there is a death, follow-up until death, and if there is no death, whatever the follow-up period. So as you see, it's in weeks here. So it's a continuous variable. So it ranges from 6 to 290. And that's what I have reformatted it in a different shape here. So the first event happened on the 6th week. The second event happened on the 13th week, third event on the 21st week, and so on. But as you see that there are some star marks here. What does it mean? For those individuals, the event did not happen, but there is loss to follow up for some reasons. So the event, we have censored that individual's follow period to 31 weeks for this patient and 47 weeks for this patient. So how does we handle it? The aim of the survival analysis is to estimate the probability of not experiencing event of interest. That means the surviving, not dying over any given time period, whether it is 5 years or 2 years or 10 years, whatever be it. And then what we do, we compare the overall survival experience between different groups of individuals. Say, for example, if you're doing a randomized control trial, you will have an intervention arm and you will have a control arm, and you see the pattern of overall survival into two different groups. You could do it in men, women, whatever the categorical variables of interest, you can compare it. And how do we do that comparison? We use something called a survivor function. I'm not going to get into the details of the statistics part of it, but it's the probability of not experiencing an event of interest or surviving up to the time of interest. And when you plot that survivor function on a curve, what you get a curve like this, starting from 100% probability. What does it mean? At the start of the trial, everyone is alive, or at the start of a longitudinal cohort study, everyone in that cohort is alive. So the survivor function at that point, survival probability at that point is 100%. So as the follow-up goes on, people die or people get censored because of loss to follow-up, so that the probability comes down. And if you plot it in a line, you get a line like this. And that is what the essential of survival, the key element of survival analysis. And what we can do from this survival analysis, now we can estimate the survival rate. Say, for example, in this survival curve, if you want to estimate the survival rate at 2 years, you plot a horizontal line from the x-axis towards and then a horizontal line parallel to the x-axis from the y-axis. So this meeting point, the 2 years, in this case, the probability is close to 0.4. So that is the survival rate at 2 years. What does it mean? 37% is, or 37% is surviving at that point in time. We can also get another statistics called the median survival time, but there is only one important caveat. We can't calculate it for all the data sets. If 50% of the participants are, the event is happening in 50% of the participants, then only you can estimate the median survival time. So what is the meaning of the median survival time? So survival probability, in case of death, the survival probability, we take it as 50% or 0.5. And then you draw a line. In this case, you see that it is 1.4 years. So the median survival time here is 1.4 years, since the probability of surviving up to 1.4 years is 0.5 or 50%. So the median survival time, how do we interpret the median survival time? Now, sometimes it's very difficult, and sometimes it's very difficult to communicate it to the patient. You must have read the book on the When Breath Becomes Air by Paul Kalanithi. And he communicated, he said that, rather than saying the median survival time is 14 months, or you have a 65% chance of being dead in 2 years, he said he would rather say most patients live many months to a couple of years, because it's a more honest description for him. Because it's very difficult to say that the survival probability of a particular individual is 0.35 or 0.45. Because what we are talking is about on an average at the population level. So communicating that message at the individual level and saying that your probability is only 3.35, it doesn't make much sense. Atul Gawande, in his book, Being Mortal Medicine and What Matters to the End, he mentioned about a study that's been conducted by Harvard researchers. And in this study, the researchers asked doctors of almost 500 terminally ill patients to estimate how long they thought that their patient would survive, and then actually followed them. So 63% of the doctors actually overestimated the survival time. Just 17% underestimated it. So it's very difficult to communicate to an individual. It's based on his probability. We can only talk about at the population level on an average. So the models and the statistical indices that we use it can be useful at the group or the population level. But that human survival is so uncertain that even the best statistical analysis cannot provide a single number for a single individual. That is something that you need to always keep in your mind while communicating the message from Kaplan-Meier survival curves to your patients. So how do we estimate it? It's relatively simple. If you just focus on how do we estimate, at the baseline, in this the previous example that I mentioned, there are 20 individuals. So at the start of the study, t is equal to 0. What does it mean? Every individual is alive at that point in time. The first death occurred at 6 weeks. The first death at 6 weeks. So no individual censored before the 6 weeks. So we know that all the 20 individuals were available at that point in time, and one death occurred at 6 weeks. So you calculate the probability, 1 upon 20, that is 0.05. That is the probability of death. From that probability of death, you calculate the probability of survival beyond 6 weeks. What does it mean? It's 1 minus 0.05, that is 0.95. So for that, the first individual who reached 6 weeks time point in the follow-up and died, at that point in time, the probability of surviving up to and including time t is 0.95. Similarly, you can calculate it for the next patient. The only difference here is that when you calculate the probability of surviving up to that time and including that time, you multiply the previous probability with that probability of death for that individual at that point in time, probability of number of death at that point in time. So again, you get another probability. And that probability, multiple patients, you can calculate it. And that probability, you plot it over a curve. And that's what the Kaplan-Meier plot or the survivor function. So here you can see that the first death happened here at time t is equal to 6 weeks. The survival probability is 0.95. The second death at 13 weeks, the survival probability goes down to 0.90. The third death happens at 21 weeks. The survival probability goes down to 0.85. So the step function that you see in the Kaplan-Meier survival plot indicates that the death or the event happened, and that's why the probability of survival goes down during the follow-up period. So you could ask, sometimes you see that the ticks along the survival curves, the ticks indicates the censoring part of it. What does it mean? For some individuals, information were not available after 40 weeks, or for some individuals, it's not available after 80 weeks. How many of them are not available? That's what this tick marks indicates if you see the tick marks in a Kaplan-Meier survival curve. So what do we do after the survival curve? Now we need to see the survival curves for two different groups, whether it is treatment groups or whatever groups. In this example, by tumor type, the two different tumor types, and we are plotting the survival curves. So you get two different curves here, one for the tumor type 1 and another one for the tumor type 2. So what does it say that the survival probabilities or overall survival is different in these two different groups? But these differences, whether it is statistically significant or not, we need to use statistical tests for comparison. So what do? We can compare the median survival time, or we could potentially compare the probability of surviving up to or any particular time point. So it's actually better to use a test which compares the survivor function over the whole follow-up period rather than simply comparing the median survival time, because it takes into account the complete information. For median survival time, as I mentioned in the beginning, we need to observe that at least 50% of the individuals in the study reach the event status. Otherwise, you can't calculate the median survival time. Therefore, what we normally use is the probability of surviving up to and a particular point in time. And the survivor curves, what you see on the two curves, we compare it using a test called the log rank test. So what it does is that the null hypothesis is that there is no difference between the groups in terms of the probability of an event, in this case death, at any time during the follow-up period. So essentially, the log rank test, when you conduct the log rank test, it can calculate, it can tell you the curves were different. The follow-up, the Kaplan-Meier survival curves, the probability of surviving up to a time t is different in the two different groups. And it assumes there is non-informative censoring. And it can actually be extended to compare more than two groups if you want to extend it to more than two groups. But the problem, one of the main problem with the log rank test is that it's largely univariate. What does it mean? You take only one variable, the treatment versus the control, or the male versus the female. Only one variable you can take it at a point in time. You cannot adjust for another variables. If you want to do, if you want to make adjustment for another variable, you need to go for the hazard models. So I'm not going to touch upon the hazard model here, but I largely explain to you what we do in the Kaplan-Meier curves. So Kaplan-Meier curves, the null hypothesis, when we are testing using the log rank test, the assumption is that the group have identical distribution. The alternate hypothesis that they are different. And when we use the log rank test, we compare these curves and see whether they are actually different. And you get a p-value out of it. And I'll give you some tips, important tips that we need to be mindful while reviewing the Kaplan-Meier curves. Curves that have many small steps means there are usually higher number of participating patients. That means it's actually good. So if you look at a large scale randomized controlled trial, Kaplan-Meier curves, you don't even see this step function. You normally see a continuous curve. And that indicates that the number of individuals in that study is relatively large. Another important information, if there are a lot of tick marks, it says a lot of censored patients. That means less data to calculate the probability. So the estimates is going to be less accurate. So that's not a good thing to happen. So here is an example for a Kaplan-Meier curve. It's been plotted in the other way around. Normally we plot the survival function. Here is the cumulative probability. It is directly coming from the paradigm trial where the enlaperal is being compared with ARNI. So what you see here is the first primary endpoint here, the primary endpoint of both the mortality as well as the hospitalization. So you see that the curves are going up. It's a smooth line. The probability, the hazard functions remains constant during the follow-up period. That's really a good curve. That is what we normally expect. But something we need to also watch out for the number at the bottom of the curve. What does it indicate? The number at different time points, number of individuals at different time points. You look at the example here. At the beginning, all the individuals were available, but at the end of the follow-up period, only a small fraction of the individuals were available. What does it indicate? At the end of the trial, the lot of censoring that happened. Many people were not available for follow-up after a certain period of time. And therefore, at this the end of the follow-up, the information that is available is relatively less informative as compared to the middle of the curves. So if it's not getting diverged initially, we would get nervous about the curves that we are plotting. And due to the paucity of the time, I'm not going to get into the details of the other curves, but just simply tell you to conclude the Kaplan-Meier curves. Look at this curve. Here you have stage 4 cancer with a new drug treated compared with another one. The blue line indicates the new drug, the red line indicates the comparator. And the new drugs here, you could see that the curves are different. And if you look at the 50%, the median survival time, it is approximately nine weeks for the comparator group, whereas for the treatment group, it is approximately 25 weeks. So what does it say is that the new drug appears to extend the survival, and the new drug is it well tolerated? If you look at the tick marks here, not much difference between the number of censored individuals between this group versus this group. That indicates that people did not lose to follow up because of some reasons in the trial. So that also indicates that it's a reasonably well tolerated drug. So probably because of the time limit, I stop here. I'm happy to take any questions. Thank you very much.
Thank you, Jimon, for an excellent presentation. It is, as we are usually not very much used to this, I think it has been a very, very good demonstration of how to look at the Kaplan-Meier curves. Any comments from Dr. Sudey, Dr. Manjari, and Dr. Chopra?
Yeah, Jiman, thanks. Excellent presentation. Tell me, if somebody is lost to follow-up, is in the terms of censoring, does it mean assume dead?
Not really, because we only take the information that is available in our study. So for that loss to follow-up, let's say if the patient lost to follow-up at 2-year follow-up for a 5-year study, whatever the information that we are available till the 2-year follow-up, we take that information. So at that 2-year follow-up, the patient is alive. We know that the patient is alive. So we don't consider event happened for that patient.
So when you say censored at that particular point for a patient who's lost to follow-up, that means in the subsequent analysis, that patient is not included. Is that right?
We will include until that point in time, because we have
Yes.
information until 2-year point of time.
Right, but
Subsequent
after
follow-up
2 years,
time.
it's not included.
So that is why when you look at the numbers at risk in the bottom of the Kaplan-Meier the curves, the numbers are drastically coming down. Normally, we would expect that the numbers are coming down because of the number of events happening in the patient population. But if there is a lot of censoring, there are a lot of loss to follow-up, the numbers drastically comes down towards the end of the follow-up. That is the reason why the numbers at risk changes from at different time points. So the different time points, the data takes different denominator.
So in the paradigm, sorry, one second. In the paradigm trial that you showed, right at the end, the numbers are very little, right? So
That's
those
right.
are the patients who have already experienced an event, or they have died, or they have been hospitalized, if you take a combined endpoint.
No. So if you take a combined endpoint, if there is an event happened, any of those combined, the composite event, that means that person's information is censored at that point in time, whatever be the first event, whether it is hospitalization, whether it is mortality, or whatever the first event that happened. But if there is a loss to follow up, the same thing happens. Censor at that point in time, we only use the information that is available till the follow-up available for that individual. So what it essentially means that towards the end of the follow-up, if there is a lot of loss to follow up, then the numbers at risk is relatively small. Therefore, the information that is available, the interpretation at that level is going to be very difficult as compared to, let's say, for a trial with a 5-year follow-up, but the median follow-up time is only 2 years. The 2-year time point is more important as compared to the 5-year time point, because only a few patients completed the 5-year time point as compared to the median follow-up of 2 years. So that is where towards the end of the curve, we are a little bit shaky in terms of interpreting the information, whether we can actually extend the information to 5-year follow-up. If the numbers at risk is reasonably large, then we are reasonably comfortable. If it is not large, due to loss to follow-up, we are not really comfortable at that point in time. And that is why people censor. Say that, let's say if you're doing a large cohort study, some people will have large follow-up of, let's say, 10 years. Some people may only have 2 years or 3 years. And we need to take a call where to censor it. Sometimes we say that let's censor at 3 years. That is where we have reasonably large number of people at risk available. If people at risk are relatively small, the information that we get from there is a lot of ambiguity, a lot of bias involved in it.
Okay, if there's one more point. So towards the end of the trial, if patients have died, then also the number is going to be less. So that is that distinction. Is it? It will be distinction.
No. Event is
lost to follow.
No, sir. Event is always I think when we design a trial, we would like to, unfortunately, although we don't want to see a serious adverse event happening, but for a trialist perspective, we all would like to have reasonable number of events, because without reasonable number of events, the power of the study will be very low. So if the event is happening for that individual, we have complete information. Even the event happened, let's say, at the first day of follow-up or second day of follow-up or 20th day of follow-up, for that individual, we have complete information. That individual is never going to be remain at risk. Another event is not possible for that individual. So therefore, event is always good for the trialist perspective, but loss to follow-up is not good.
Yeah.
If the numbers at risk is coming down because of the loss to follow-up, it's a serious concern.
Right.
Raymond, one question regarding, I think this is relevant for the students as well. Very often, only one p-value is given for a Kaplan-Meier curve, and suppose that even for the paradigm study, the median duration of follow-up is 2 years, and they have a Kaplan-Meier which extends beyond to 5 years and beyond. Now, for when it comes to smaller scale studies, often residents tend to, they tend to draw the Kaplan-Meier curve very long, far beyond the median duration of follow-up, and only one p-value is provided. So, is there a statistical definition as to how long a Kaplan-Meier may be extended beyond the average duration of follow-up? And if one p-value is given for a Kaplan-Meier curve, what is the ideal time to give that p-value at a follow-up period?
Well, I think there is no clear answer to it, but now largely we look at the numbers at risk in the bottom of the table. If that numbers at risk in the bottom of the table is reasonably large enough, then we have reasonably good level of information beyond that point as well. But if it's coming down to something like 5 patients, 10 patients, 25 patients beyond, let's say, 5-year follow-up, then that's not really useful for us, because it's not going to add anything. It's just going to add some some noise to the data set. So that is where we take a call of right censoring at normally just beyond the median follow-up time, not the median survival time, the median follow-up time. If the median follow-up time is, let's say, 3 years, we may say that, okay, reasonably up to 4 years, we have reasonably good number of people at risk. So that is reasonably acceptable for us. But if you, let's say, 10 individuals, we have follow-up data till 10 year of follow-up and extended to 10-year follow-up, that is not a good way of doing the Kaplan-Meier curve. And always, when you generate a p-value, you only get a one p-value because when you do multiple testing at different point in time, it adds to the multiplicity issues as well. So we need to adjust for the multiple testing corrections if you're doing multiple, if you're generating multiple p-values based on the follow-up time. That's not a good idea to do in a trial or a follow-up study.
Thank you, Dr. Jeeman. Venu, sir?
Yeah, I think there are no further queries on this. Thank you, Jeeman, for an excellent presentation. I think we have learned quite a bit. At least I have learned a little bit from this. Thank you so much.
Thank you very much.
Now we'll go to the second part of the program today, that is a case presentation. The case is being presented by SKIMS Srinagar. Dr. Harjab Singh will be the case presenter. And the student panel is from NIGRIMS Shillong, Dr. Shashank, Dr. Devashish, and Dr. Amish. And the examiners are, we have a very distinguished panel of examiners, Dr. Rajan Joseph Manjaran, who is a professor and head of the Department of who is a professor of cardiology at Sri Chitra and Pushpagiri Institute of Medical Sciences, Dr. Sudhir Kumar, former DME, Government of Kerala, Dr. Hilal Ahmad Rathar, who is the head of the Department of Cardiology at Srinagar SK Institute, and Dr. Amish Mishra from NIGRIMS Shillong. So with this, can I invite the presenter, Dr. Harjab Singh, to present his case presentation?
Good evening, all of you. I am audible to all of you.
Examiners, sorry. Are the examiners are all present? Yes. Dr. Manjaran, Dr.
Yes, it's audible. No problem.
Dr. Rathar, yes. Yeah, can we go ahead with the case presentation?
Yes, good evening, everyone. And my name is Dr. Harjab. I am presenting my case, and I am from SKIMS Srinagar. And sir, can I proceed, sir? And I am audible to all of you. Okay, sir. Thank you. So we'll start the case, sir, and first start with the patient information about that. She was a 55-year-old female, and she was resident of Kashmir, and she was a Muslim by religion. Occupation, she was working as a junior health inspector, and she was admitted to OPD, and history source was patient and her daughter as well as her mother. So presenting complaints, give a history of breathlessness from last 19 years, palpitations from last 18 years, and bluish discoloration of body from last 4 years. So history of present illness, patient was in her usual state of health and 19 years back when her age was 36 years. And then she started with breathlessness. It was a gradual in onset and it was progressive in nature. Earlier, patient used to walk 2 to 3 kilometers and also doing work at her fields. And patient was first started feeling breathlessness on walking around 2 to 3 blocks. And she also started feeling breathlessness on digging in fields with spades and started feeling breathlessness on climbing one flight of stairs. It was NHA class 2 at that time. Then patient was taken to the local hospital there and given some medication likely diuretics and managed on OPD basis. Symptoms then slightly improved and patient started avoiding working in the fields and walking long distance. But she was not taking medication regularly and she was not on follow-up regularly at that time. Then after 9 years, her age was 45 at that time. She was started feeling breathlessness even on walking one block and feeling breathlessness on climbing few steps of stairs. And then it further progressed and she was breathless even on doing personal activity like taking shower, dressing herself, dishwashing. And then patient again her symptoms gone from NHA2 to NHA3 at that time. Then again she consulted private hospital at that time and they did some investigation and they told her that she is having some heart disease which is present since birth, likely congenital heart disease, and she given medication which improved her symptom again minimally and patient further curtailed her activity. But from last 4 years, from age 51, she was feeling breathlessness even on rest and she was not able to carry out any physical activity without discomfort, and her symptoms progressed from NHA3 to NHA4. No history of any orthopnea, PND, or platypnea associated with breathlessness. No history of chest pain or cough associated with breathlessness. Sir. Then she also gives history of palpitation, and palpitation started 18 years back. It was gradual in onset and offset, and they were persistent type of palpitations, and it was exaggerated by exertion, and it was pounding in character. From last 4 years, she was saying that intensity of her palpitation were decreased, but there was no history of any loss of consciousness associated with palpitation, polyuria, sweating, or chest pain associated with palpitations. No history of any beating in the neck around when she feels the palpitations. There is a history of bluish discoloration of body from last 4 years, which was first noticed by her daughter, and presence on fingers and toes, oral cavity also, and aggravated by exertion. But there were no diurnal variation in this blue discoloration. It was decreased on taking rest, not relieved by any specific posture. And there is also a history of yellowish discoloration of eyes from last 3 years. It was also noticed by our daughter, and it was gradual in onset, but non-progressive type, not involved any other parts of the body. No history of any itching or pain, abdominal loss of weight, or fever associated with jaundice. And no history of any hematemesis or melena associated with that. There is history of epistaxis 2 years back. There's a single episode, she was saying, and spontaneous in onset. It was profuse bleeding and associated with clots. Also stopped after some time and after applying local pressure, and patient consulted local hospital at that time when she had that episode. But there was no history of any gum bleeding, menorrhagia, or easy bruisability, and no history of any hemoptysis. No history of any abnormal body movements or focal neurological deficit. No history of any bluish discoloration at birth. No history of any syncope, chest pain, PND, or hemoptysis. No history of any pedal edema, abdominal distension, oliguria. No history of any tinnitus or headache. Then going to past medical history, she gives history of a recurrent respiratory tract infection in childhood. This recurrent respiratory infection, they started around 2 months of age. And when patient was taken to local hospital at that time and given IV antibiotics, and symptoms started improving after she was 1 year of life. And she has no symptom after 2 years of age. There is also a history of feeding difficulties, that sweating, bile, feeding, poor weight gain. They were also started along with the respiratory tract infection around 2 months, and they also improved after 1 year of age. And a patient was asymptomatic after 2 years of age. Well, she was only consulted local hospital at that time, but it was not evaluated at that time further. What was the reason behind that? And no history of any squatting or cyanosis associated with that. Patient was diagnosed with hyperuricemia 2 years back, and she was taking medication for that, febuxostat, and there was no history of any surgical history in the past. Recently, she was admitted in private hospital for and phlebotomy was done in that hospital. Family history, she gives no similar complaints in the family, no history of any hypertension, diabetes in the family. Her sister died at the age of 3 years, but was not evaluated and died at home. No significant paternal history. Personal history, she was non-vegetarian, appetite normal, sleep adequate, bowel movement normal. There is a history of increased frequency of micturition. She was non-smoker, non-alcoholic, no substance use. Obstetrical history, she was married at the age of 19 years in 1987. She was granted to para to life to no history of any abortion. First child at the age of 23 years, and it was a male child born by normal vaginal delivery at home and delivery conducted by the midwife, but there is no history of any breathlessness, palpitation, syncope during the pregnancy, no history of cyanosis in child at birth. Second child at the age of 26 years, and female child born by normal vaginal delivery at hospital. No history of any breathlessness, palpitations, syncope during the pregnancy. No history of any cyanosis in child at birth. Socioeconomic history, she belongs to upper middle class family. And a summary of my history. 55-year-old female with history of recurrent respiratory tract infection and heart failure in childhood, followed by asymptomatic period. Then there is a starting with the progressive type of breathlessness from last 19 years. Initially, it was NHA2, then progressed over a year to over multiple years to NHA4, and is associated with exertional type of palpitations from last 18 years and central type of cyanosis from last 4 years. She also gives history of jaundice from last 3 years and one episode of epistaxis 2 years back. Past history significant for hyperuricemia, recent phlebotomy for polycythemia. No history of any orthopnea, PND, angina, fatigue, syncope, or right heart failure symptoms associated with that, sir. And sir, my differential.
Well, no, don't give. Like, I think we should ask the Shillong students to discuss the story. I felt that Mr. Singh has given a reasonably good detailed description of the history of the patient in a sequential manner also. Of course, he has given a lot of details. So, Sudhema, shall we ask the Shillong people to discuss, or you want to make a few comments?
I agree with you, sir, but I think at postgraduate level, it need not be stretched that much. Should be precise, because stretching that Disney is not, it's a good presentation. I have to appreciate that we have touched upon all the points in detail. But when you are presenting at postgraduate level regarding that breathlessness, you can say to begin with, it occurred on this thing. She was in class 2. And then over the next 3 years, it progressed to class 4, 3. And that's all what is needed at your level, because you should know NYHA classification. That we expect you to know that. Okay,
Yes.
that is one. Second is, the only thing is, she is 55 years. Okay. So history is from her mother, she must be around 70 years. Very unlikely that you will get a detailed history in infancy or early childhood, what you have discussed. That's only my reservation. Because she may not be able to she cannot recollect. How you got that history? That's the only problem. Because her mother should be around 70 years to recollect the details, because that was a home delivery. So at that time, it was not well planned. So home delivery to recollect the details like recurrent respiratory infection requiring IV antibiotic, frequent increased precordial activity, all those things. I think it may not be easy to get such a history. Okay, that's only my comment. But otherwise, we have put everything perfectly. And similarly, the obstetric history, you need not say that she has 2 children and full-term normal vaginal delivery, home delivery, uncomplicated. That's all what is needed. Regarding the palpitation, you said when you discuss about the palpitation, our aim is it arrhythmic or not? Because she was having palpitation continuously. There is no question of polyuria, syncope, all those things. Okay, that you discuss when you get paroxysmal or episodic palpitation. So she was getting palpitation for the last 10 years, which was almost persistent. So then it is unlikely to have polyuria, syncope, all those things. So you can underplay that symptom of palpitation also, because we'll concentrate on the main symptom. Okay.
Okay, sir.
Okay, sir.
Thank you, sir.
Only advantage of going into it, some of the details of the history is the candidate will have an opportunity to exhibit his knowledge about the disease process, and sometimes it will be useful to impress the examiner also. So I feel that where it is relevant, some of the details can definitely be presented. At the same time, you may draw conclusions out of that. As Suyamar has rightly said, palpitation could be either a disease-related palpitation or it could be an arrhythmogenic palpitation. And what is you can draw a conclusion. I think this is a walling overload type of a palpitation. And if the patient is getting symptoms like rest palpitation or irregular palpitation, you can start thinking that it could be a arrhythmogenic palpitation. So wherever there is a possibility of exhibiting your knowledge, I think you can definitely do that. That will be helpful to impress the examiner also.
Discussions. Shashank et al. You
How will you
discuss
start the
this.
discussion, Shashank? How will you start the discussion? Shashank,
Yes, sir. Yes, sir.
how will you start the discussion? Discussion is you should not repeat what has been told in the story. You have to draw conclusions, and if you think that there is a need of a supportive evidence, that can be stated.
Definitely.
First, put the points which you want to discuss in the chronological order. So
Sir,
1,
definitely.
2, 3 points. Then try to correlate. Okay.
So definitely it seems to be a left to right shunt, which started as a left to right.
Rather than drawing a conclusion that way, I would start from zero. Then is this a guy? What is the system affected? Whenever a history is taken, I think I usually start that way. That which system is affected? Is it a cardiovascular system disease? Of course, we know that this is a cardiovascular system disease. But starting from the basics, I usually teach my students that start with whether this is a cardiovascular system disease or not. Then which side is affected? Right side, left side, both sides. And then what is the nature of the illness? Is it a volume overload, pressure overload, or a myocardial disease? What is the pathophysiology of the disease process? And then are there any complications? So in that order, you will get a sequence of events which will help you to come to a proper diagnosis.
Yes.
So what you can do is to attain that when you are discussing the history, you take the point. That is the way I discuss. On which are the important points in the history. One is breathlessness. Second is palpitation. Third is cyanosis acquired. Fourth, the possible history of symptoms in childhood. And epistaxis may not be very relevant in this case, may be relevant, but we cannot discuss too much on that. Jaundice also, we need not discuss too much on that, but you have to answer that. Hyperuricemia, everything is very clear. So we have to think three things. One, he has put rightly from the history. If it is really right, the patient has problems from the second month onwards. Then remaining asymptomatic. And by the age of 35 years, becoming symptomatic in the form of breathlessness. And then later developing cyanosis. So if you put like that, it is easy for you to discuss. Each thing you have to discuss. So that history, if you accept that history, you can say it is a congenital heart disease. So how will you start that history? That's the way I approach this case. Okay, as Sir said, obviously we are dealing with heart disease, cardiovascular system. Second, which group of disease we are likely to be dealing with? Is it a congenital heart disease or an acquired heart disease? If it is an acquired heart disease, you start from the age statistically, valvular heart disease, hypertensive heart disease, ischemic heart disease, cardiomyopathies, or rare diseases. So that is the way I approach this case. If you are dealing as a congenital heart disease, are you talking about a cyanotic congenital heart disease, acyanotic congenital heart disease, or an acyanotic congenital heart disease which has become cyanotic later? If that is my approach, if I proceed like that, I may be able to make the diagnosis in a better fashion. That is my approach. As Sir said, you can put it as a left heart, right heart, or biventricular, or both heart. Both are acceptable. Okay, go ahead now. Go ahead with your discussion of the case.
Sir, first of all, it is a cardiovascular system. It is a acyanotic heart disease, which started with initially owing to the history of recurrent respiratory infection. Probably there is a left to right shunt with increased pulmonary blood flow.
Which left to right shunt usually gives rise to recurrent respiratory tract infection, and which left to right shunt is not usual to give rise to significant respiratory tract infection? And what is the mechanism of respiratory tract infection in a left-to-right shunt?
So in VSD and PDA, respiratory infections are more common compared to ASD, sir. Pre-tricuspid.
Yes. So what is the reason that these patients develop recurrent respiratory tract infection?
So because of
Do you have a reference for that? That is, respiratory infection is more in ASD and PDA. I'm not sure.
He said VSD and PDA.
No, he said ASD and PDA.
VSD and PDA, I told, sir. VSD and PDA.
Oh, I thought he said
atrial septal defect or ventricular septal defect?
Ventricular septal defect, sir.
Okay, fine. Why? That's the question.
Because of the shunting that takes place, sir, more of the blood is being diverted from right side to the left side without being passed through that without a filtering process, and the blood directly goes into the lungs, and because of the more amount of volume that is reaching into the lungs, that is one of the cause for recurrent respiratory tract infections.
May not be completely right. Okay.
Then why it is that some which lesion will have a larger shunt? Is it ASD, VSD, or PDA? If you look at three lesions, which lesion can have more shunt? Is it ASD, VSD, or PDA?
VSD, sir.
VSD.
Which one?
VSD, ventricular septal defect, sir.
Not shunt. No. Very often, when the shunt is well established, ASD can have a much larger shunt. They can have a larger cardiac size, can have a larger shunt. But ASD does not give rise to too many respiratory tract infections, unlike VSD and PDA. So there should be something different. What is the difference?
I think more important that recurrent respiratory infection is the next symptom. Recurrent respiratory infection is a very non-specific symptom. Because if you get 100 infants with recurrent respiratory infection, I don't know how many percentage. Very, very rare can heart disease because so many other reasons. But recurrent respiratory infection is a very non-specific. But another symptom which is said, if it is right, what is that?
Second rest cycles, sweating. That sweating that takes place while the baby is being fed. The second rest cycles.
Pardon?
Suck rest cycle, sir, while breastfeeding.
No, he said they didn't say suck rest cycle. He said increased precordial activity and increased sweating in early childhood. Now, there the point of ASD, VSD comes. When this occurs, in VSD and PDA, these things occur very early. So that if you take 6 months, there will be VSD or PDA because the shunt will be established. Whereas in ASD, the shunt is get established later. And if you take a 5-year-old or a 10-year-old patient, the ASD will have the largest shunt because the PVR has come down. The pulmonary artery has dilated. The right ventricular compliance has improved. The left shunt progressively increases. Whereas in VSD and PDA, post-tricuspid shunt, they develop early pulmonary vascular resistance so that the shunt will be relatively restricted. So if you look at the magnitude of the shunt, in the first year or 2 years, VSD and PDA will have relatively larger shunt compared to ASD. ASD, the shunt gets established over the next 2 years so that if you take later, the volume of left right shunt will be much, much more. So if you take recurrent respiratory infection, the mechanisms which usually asked, one is the dilated pulmonary artery and accompanying arteries compressing the respiratory airways. Second is in VSD and PDA, post-tricuspid shunts, they will have heart failure. They will have left heart failure, which predisposes to recurrent respiratory infection. So very early recurrent respiratory infection in the first year, it is unlikely to be ASD. Because ASD, the pulmonary artery gets dilated only later. The shunt gets established only later. There is no left ventricular failure. So conceptually, or looking at the basic hemodynamics, ASD is less likely to have recurrent respiratory infection in the first 2 years. But we have been taught, or everybody has said, when you get recurrent respiratory infection, it is ASD like that. But you can't explain that. Sir, am I right, sir?
Yeah. The most important thing is that the left heart failure, LV failure, plays a major role in the development of recurrent respiratory tract infection. Now, what is the why do these patients develop recurrent respiratory tract infection at all? It is thought that when the patient develops heart failure, especially left heart failure, there can be an edema of the mucous membrane or the bronchi as well as trachea that will result in less movement of the cilia of the lining cells of the trachea as well as bronchi. This celiac movement is actually moving outside, and it actually tries to expel the bacteria getting through the air, through the breathing air into the lower respiratory tract. So the lack of cilia movement is thought to be one of the many reasons that these patients can have infection reaching the lower respiratory tract, and they may present with pneumonia or whatever it is. So this heart failure is not a feature of ASD because it is a pre-tricuspid shunt. The patients with VSD and PDA can have left heart failure, and that is the one very important reason for these patients to develop recurrent respiratory tract infection. I want to ask you, as Sudhema rightly pointed out, what do you mean by recurrent respiratory tract infection? What is the definition? What is the normal respiratory tract infection in a normal baby in the first year, second year? What is the number of respiratory tract infections which can be accepted as normal in the first year of life, in the second year of life?
Less than 2 admissions.
No, you can go up to 4 to 6. First year
More than 6, if more than 3, we suspect. If more than 6, it is most likely, sir.
Yeah. It is 4 to 6 is 4 to 6 can be taken as the up to normal, and in the second year it can be up to 4. So the respiratory tract infection is not a very uncommon thing in the early part of the life. But of course, if the patient has to be hospitalized and had to be given intravenous antibiotics, then there's a different question. But respiratory tract infection, in a normal child, can be up to 4 to 6 in the first year and up to 4 in the second year. So
it's a lower respiratory tract infection. So the problem is in the lower part. So you have to say lower respiratory tract infection requiring hospitalization. Sir, our Hilal sir is also there, sir.
Yeah. But from history, if we see, there is only one episode of respiratory tract infection he had at 2 months of age. Is that, Dr. Harja, what you said?
He was having some multiple respiratory tract infection. Exactly, number of episodes. They have not told me how many times he had that. They have not exactly told.
Very difficult to get that.
They were more sure about heart failure symptoms because she was not able to feed her baby. They were more sure about that symptoms because they were more.
Sir has already told you. As sir has already told you, a 70-year-old lady will not be
Sudhema, can we proceed
and
with
she
the
and the patient himself saying that her mother also told her when she was around 30-40 years that during childhood you used to get sick, you will not feed that, and she was also knowing about that. Patient also
So
knowing about that.
You are telling that the feeding problem, heart failure symptom was more striking in this case. So
Yes,
that
sir,
you
yes,
should have highlighted.
Yes, it is.
Okay,
So,
then you can say that. So that is one symptom. Second symptom which sir wants to discuss. Am I right, sir?
Yeah. Now, just a second thing. Say, what are the usual symptoms which you will depend upon to come to a conclusion that the patient had a heart failure, especially in the first year of life? What are the symptoms which will make you think that the child might have had heart failure in the first year of life?
I think Shashank has answered that initially.
Sir,
The first few months.
That will be, sir. Success cycle if the baby is having. Apart from that, if there is a success cycle, is very suggestive of, sir, the patient is in heart failure, sir.
Sweating while feeding.
Sweating while feeding, not able to complete her feed. She can have, sir, this abdominal the pain at the abdomen can have because of this hepatomegaly. She can have tachypnea. She can have
the most important symptom the parent or the grandparent observe is the tachypnea.
Tachypnea, sir. That is also included in the. That's why included in the classification of this.
That's a very important symptom. They observe and bring the baby to the pediatrician. That's very important. And head sweats. What is the mechanism of head sweats? What is it due to?
Sweating is stimulation of which system?
Sympathetic.
Sympathetic system. It is a stimulation of sympathetic system, which when the baby is in heart failure, sympathetics are stimulated, and that can result in the head sweats. And of course, you have said other symptoms which include, and also baby prefers an upright posture. Sometimes most of the babies like to be in the lap of the mother, but the babies with heart failure, they may like to be in the upright posture, and they may prefer to be in the shoulders rather than on the lap. So that also is something which you can always ask for to find out whether the patient had features of left heart failure. Okay, go
I
ahead.
also agree with that. That is dyspnea during feeding, that is exertion. Exertion for the infant is feeding. So the child becomes dyspneic, so interrupted feeding, suck, cycle agreed. And the sir said that after feeding, the child has to be put in the shoulder rather than in the lap for some time. Then increased sympathetic activity is sweating, mainly in the forehead, because sweat glands in infants are more on the forehead. Then increased precordial activity and increase subcostal, intercostal, and abdominal movements that the parents will notice. Tachypnea, as sir has said. Then you can say that the secondary things, that is, because the child is not feeding adequately, there will be failure to thrive. Okay. Then the other point which our friend have said, that is because of the abdominal distension, they can have abdominal pain, but they can't tell the pain. So they may be crying also, incessant cry, or not incessant cry. After feeding, it may be crying, but that's not a common thing because crying will aggravate the breathlessness. So crying is not a common. I have not observed that, or I have not seen people or the mothers telling that too much. I have not asked in detail also, but sacrocycle, classical, but it can occur in any respiratory disease. Increased sweating, increased precordial activity, because the sacrocycle can occur in even in lung disease. Okay, because they become dyspneic. Increased precordial activity with subcostal retraction, as sir said, tachypnea. So that will be the features of heart failure.
Of course.
Okay.
What is the Sudhemar said that usually VSD and PDA, the shunt is established quite early in infancy, while the ASD shunt is established delayed. What is the reason? What is the mechanism? What is the reason?
Because below the ASD shunt there is RV that is more compliant, and so it takes time for that, and that's the reason
you should tell what is the mechanism of establishment of shunt in VSD and PDA. What is the mechanism of establishment of the shunt in ASD? Then only it becomes very clear.
In VSD and PDA, it is because of the pulmonary vascular resistance changes that is occurring. The fall in pulmonary vascular resistance that is occurring after the birth of the child. They are occurring usually at the 6 to 8 weeks when the fall is maximum, and then
what is the normal pattern of fall in pulmonary vascular resistance?
So normally the pulmonary vascular resistance falls within 1 to 3 weeks in normal child, sir. And
no.
First we have to say
no. What happens within 24 hours? What happens within 24 hours?
When the child, sorry, when the child takes
the first breath, 50% falling PVR.
First breath. See, because the lungs are immediately expanding, the capillaries are opened out, the pulmonary vascular resistance drops. 50% falls when the child takes the first breath.
Yes, sir.
And then the rest of 50% over a period of 2 to 4 weeks. Slightly it varies.
Yes,
so
sir.
in the first breath itself, there can be some establishment of the shunt in a patient with VSD with PDA. But in an ASD, what is the mechanism?
Before that, VSD, with the first breath, even though the pulmonary vasculature opens, it is a pressure dependent. The RV pressure and the PA pressure are transmitted from the systemic side. So that means the pressure is transmitted. There is a stimulus to the pulmonary vasculature. So the pulmonary vasculature will not regress normally. Okay, there will be delayed one. Okay, sorry, the pulmonary vascular resistance remains relatively high, but the shunt gets established very early because it's a pressure dependent shunt. Okay, because even when the pulmonary vascular resistance falls, the high pressure is transmitted to the right side. So the shunt gets established early, but the PVR will remain relatively high. Okay. Whereas in ASD, what happens, sir, as asked?
Now before that, but when even though there is a fall in the pulmonary vascular resistance and pulmonary pressure slightly falls, a shunt is getting established. But the shunt may not be too large. What is the mechanism or what is the phenomenon by means of which the shunt is restricted? There is an effect which is described as, have you heard of Baylis effect? Have you heard of Baylis effect?
What does happen, Dr. Haja? What happens in ASD? Why is ASD shunt delayed?
So in ASD, shunt is late because in below ASD there is RV that is more compliant and it will take time.
No, it's not RV possibly.
What is the just like the pressure dependent shunt in VSD and PDA? What is the thing which decides the left to right shunt in a patient with ASD?
The ventricular compliance. You have to say the ventricular compliance.
It is the compliance of the left ventricle.
Two ventricles.
Especially the difference in compliance between the left ventricle and the right ventricle. So the right ventricular compliance definitely in an adult is much more than in the left ventricular compliance. And it takes some time for the right ventricular compliance to improve after birth. It takes about 3 to 4 months. And then only the shunt is established. As the RV compliance improves, the shunt is established, more and more shunt is established from left atrium to the right ventricle, right atrium to the right ventricle. So the establishment of the shunt in a patient with ASD is depending upon the compliance of the right ventricle. As the right ventricular compliance increases, the shunt also increases.
So the left ventricular compliance also contributes because the left ventricular compliance progressively increases also. The right ventricular compliance, so the left ventricular compliance decreases. Right ventricular compliance increases. The pulmonary vasculature regresses completely. Whereas in post-tricuspid, the pulmonary vasculature doesn't regress because the pressure is transmitted straight away. So the shunt is restricted in VSD. It is relatively restricted. You won't get very large shunts. So over time, because there is no pressure transmission, the pulmonary vasculature goes on regressing, recruiting more pulmonary smaller vessels. So if you look at the pulmonary vascular anatomy and the capacitance, which is much more in ASD than in VSD and PDA. So two factors. One is the ventricle we have said. Second is the pulmonary vascular capacitance goes on increasing, whereas that is prevented in VSD and PDA.
In a patient with ASD, actually the regression of the pulmonary vasculature is perfectly normal. Because the shunt is not established early in the regression of the pulmonary vascular resistance, and most of the regression of the pulmonary vascular resistance and the pattern of opening up of the pulmonary vasculature, everything is perfectly normal in a patient with ASD.
What is the role of RA compliance in ASD? Right atrial compliance.
And second, one more point I want to just clarify one point. But in a patient with VSD and PDA, there is something known as Baylis effect. Baylis effect is that as the pulmonary vascular resistance falls, pulmonary pressure comes down, a shunt is established in a patient with VSD as well as in a patient with PDA. When the shunt is established, there is a stretch of the pulmonary vasculature. In the childhood, the pulmonary vasculature has got smooth muscles, and when the pulmonary vasculature is stretched, immediately there is a recoil phenomenon in the pulmonary vasculature, which is known as the Baylis effect, and that will result in restriction of the shunt. So a large shunt is not established immediately, and that is why patients with VSD may not come with a heart failure within the first 4 to 6 weeks, and also the VSD murmur may not be immediately audible. VSD murmur a child may be discharged saying that there is no evidence of heart failure, no evidence of heart disease, but a murmur may be established by about 4 to 6 weeks. And when the child is brought back with the symptoms of left heart failure or with symptoms which you like feeding difficulty or unexplained crying or tachypnea, then you will find that the shunt is established and the murmur has appeared. So in a patient with VSD and PDA, you may not get a murmur immediately. This is because of the Baylis effect, where there is a recoil of the pulmonary vasculature restricting the shunt. So immediately shunt is not established in large quantities. The shunt will be established, even though there can be a mild amount of shunt, the shunt is really gets established only by about 4 to 6 weeks. That is why the murmur appears in a patient at a later stage, about 4 to 6 weeks after the birth of the baby.
Dr. Kumar,
So
is
in
there
this,
some role of RA compliance also in ASD?
okay. Now,
Right
in
atrial
this
compliance,
case,
right atrial compliance,
yeah,
does it play some role in ASD this hunting?
okay. The point is the compliance contributed by the left atrium and the pulmonary vein. Left atrial compliance is less compared to the right atrial compliance. That promotes the left-right shunt. But the temporal sequence will be based on the ventricular compliance and the pulmonary capacitance. Okay, let us, because we have to discuss so many things. Am I right, sir? So we have
just one more point. In a patient with ASD, what will be the pressure in the left atrium? Which chamber pressure controls the, or which chamber pressure controls the left atrial pressure in a patient with ASD?
Which controls pressure?
Hemodynamically, the pressure in the left atrium is normally, we know the left atrial pressure is mostly controlled by the left ventricle in a normal person. In a patient with ASD, which pressure controls the left atrial pressure?
Ravi.
Right ventricle.
Right ventricle.
Yes, it is the right ventricular pressure which controls that is because the blood flows from the left atrium through the right atrium into right ventricle, and it is the right ventricular pressure and the compliance which controls the flow as well as the pressure in the left atrium. Okay.
I think I may add like this. There are three factors. One is the right ventricular compliance, which is progressively coming down. On the left side, the left ventricular compliance, which is progressively coming down, and the pulmonary venous tone contributing to the flow from left to right. So from this, we have concluded that this patient has developed symptom of heart failure by the second year. And then what happens? So we will go to the next phase. So because we have to discuss so many things. So what has happened after that? Yes, Shashank? The patient symptomatically improved. Why?
Yes, sir.
Why? What is the mechanism?
What is the reason?
Because of the increased pulmonary vessels resistance and reduction in the shunt value, the patient became less symptomatic and the patient started feeling better.
So there is a progressive rise.
What are the mechanisms by means of which shunt can become less and the patient can become less symptomatic?
So generally the pulmonary vessels are supposed to be have low resistance. Because of the high blood flow, there are some pathological changes that takes place into the vessels layer.
Okay, the PVR goes up. That is one. The pulmonary resistance progressively rises. First question is, apart from that, what are the other mechanisms by which the patient becomes symptomatically better? The symptoms of heart failure was due to left ventricular volume overload because of the large shunt, LV failure. And when there is an increase in the PVR, the left-right shunt comes down. The volume coming to the left ventricle comes down, left ventricle improves. Fine. Sir's question is, what are the other mechanisms?
Some patient develop this acquired PS also, that is known as Gassel's phenomena. They also improves after initial titration.
But before that,
Before that, anything that can happen to the shunt?
Can something very favorable to the baby? Something which is
one thing favorable and three things unfavorable. Favorable, which is the commonest thing. Size of the VSD, what happens?
Size of the VSD comes down.
Comes down.
Yeah.
VSD size
VSD can itself close. Some VSD, if they are small, they can close by itself also.
Yes. Not even large
VSD. Sometimes they can be closed by septal tricuspid valve leaflet. Sometimes they can be closed by this aortic valve cusp also, sir.
See, if
the favorable thing is
moderate size VSD can become a small size here. Large VSD.
You have the favorable thing, which is reduction in the size of the VSD, which occurs even with large VSDs. It becomes small. Some VSDs may close even. That is favorable.
Yes.
The mechanism of closure could be favorable or unfavorable. There are different mechanisms. What are the unfavorable things which reduce the left right shunt? One, we said PVR going up. What are the other things?
Which can occur slightly at a later age, before the age of 12.
No, closed by the coronary, coronary cusp. No, this non-coronary cusp sometimes closes.
There can be sometimes there can be prolapse of the.
Sometimes yes, and it can develop AR later on. The VSD permanently closes and the patient develops AR in these patients, usually before 10 years of age. Sometimes they can. Sometimes the patient can have closure because of septal tricuspid leaflet, and later on they develop this acquired Gerbeau defects. These patients where they close by this, by septal tricuspid leaflet.
So no, see in a patient with VSD, what are the mechanisms by means of which the left to right shunt can come down and patient may become less symptomatic? One is reduction in size of the VSD, or it may be even closure of the VSD. Two,
elevation of the PVR which we discussed.
Increase in the pulmonary vascular
development of acquired PS.
Yes, three. And when development of pulmonary stenosis. 4.
You have said AR.
Aortic regurgitation. In aortic regurgitation also the shunt can become less. Why?
Yes.
Why the shunt becomes less?
You have said that what is happening when the aortic leaflet prolapse? It prolapses into the.
It closes the VSD, no, sir?
Partially closes.
Non-coronary cusp collapse and it closes the VSD because of venturi effect. It collapse and closes the VSD. That's why they develop AR and VSD closes, sir.
Now, where does the aortic regurgitation drain into?
Yes, sir.
Why does AR happen? Where blood go from aorta? Once the patient develops aortic regurgitation in a large VSD, what will happen to aortic regurgitation jet? The sir is asking you how is aortic regurgitation decreasing the symptoms? Regurgitation should technically increase if you are saying that the shunt is going to left ventricle.
So what you have to tell is aortic regurgitation, the aortic valve prolapses into the ventricular septal defect more with the subpulmonic VSD, and the VSD may get partially closed at the expense of progressive AR.
Yeah. So.
Is the prolapse of the aortic cusp more frequent in large VSDs or medium-sized VSDs or small VSDs?
Large.
You have said venturi effect.
Large size.
You have said venturi
small
effect.
VSD. There's more common in small VSD. This one.
Small,
but
relatively small.
Outlet
Actually, is more common in large. This is more common in small, sir.
It says relatively small or
it can
small.
It's not small, relatively small, and more in subaortic, this subarterial VSD, sir.
Why that difference? Why that difference? Because the dragging effect, there are two things. One, basically, there is an abnormality of the aortic annulus and aortic leaflet, basically. But the venturi effect is more in
small to
moderate
also
size,
that
because
septum,
there is a.
And
also,
let me
give support.
Wait. In a small to moderate, it depends on the RV gradient. That produces the velocity and the venturi effect. So that is more in a relatively small VSD, whereas in a large non-restricted VSD, there is no venturi effect because the ventricular pressures are the same. There is no significant gradient. So venturi effect or dragging effect will be relatively less. Whereas in a relatively small VSD, the RV pressure has already fallen. So there is a good left-right shunt. There is a high velocity jet which drags this thing. That is why it is relatively more fit. Yes,
and also in a patient with when the aortic valve prolapses, what happens to the venturi effect? And the aortic valve prolapses into the ventricular septal defect. What will happen to venturi effect?
Will decrease. It will decrease.
It will decrease. Why? What will happen to when the VSD becomes smaller? Will the velocity be more, or venturi effect will be more or less?
More.
As the aortic valve prolapses, the venturi effect will be much more, and it will further pull down the aortic valve.
So it is only systolic prolapse, then it becomes both systolic.
That is why in a subpulmonic VSD or a small VSD, If there is an AR, it is an indication for early intervention. Because the early AR is likely to progress.
Yes,
So
sir.
there are three
Most
things:
within
on
10
lack of
years.
support. Second is basic abnormality of the aortic valve apparatus, plus mainly contributed by the hemodynamics.
And what is the age in which AR can occur in a patient with VSD?
So it starts within 2 years of age, and
No, it occurs relatively late, not within 2 years.
Usually it occurs by about 4 years of age, and usually if the patient did not have any AR up to the age of 12, then the patient will not develop AR. Because as Sudaimar was pointing out, it is not only the Venturi effect, it is an abnormality of the aortic cusp also contributes. So if the patient has not developed any aortic regurgitation by the age of 12, then it's very unlikely that the patient will have aortic regurgitation as a complication of VSD.
So this patient's heart failure improved by some of these mechanisms. Now we have to see what is the likely mechanism. The patient improved and sustained improvement for a long time. If we had seen the patient by 30 years, the patient is asymptomatic. So we may say it might have closed. Now, the patient developing symptoms, how will you know whether it is favorable, totally asymptomatic? And examination. Second, the patient is developing symptoms of Eisenmenger, symptoms of RVOT obstruction, and symptoms of AR. That is what you have to look in the natural history. In this patient, the natural history of the symptoms suggests the possibility as what has happened. The patient was remaining symptom free till about 35 years. Then the patient started developing symptoms. So, based on the symptoms which occurred after the age of 35 years, what is the likely possibility? Is it AR? Is it Eisenmenger? Or is it Gazole VST? That is developing RVOT obstruction.
And also, what is the defect? Is it VSD? Is it ASD? All those things should be discussed.
Yeah. So because we said that the patient has heart failure in the second month and all those things, we think it is a post-tricuspid shunt. Shall we proceed like that, sir?
No, I would like to still keep in the thought process that ASD should be still considered. But of course, I agree with you that since if the history given by the mother that before the age of 2 years the child had which is suspicious of heart failure, I think a VSD should be brought in as in the discussion. Yes, but the VSD developing cyanosis at the age of 35, 40, bit too late.
It's too late.
So that comes my question. Is it AR? Is it Eisenmenger? Is it RVOT obstruction? Gazole VSD? What is it likely to be? One thing is out, or two things are in. What are the two things in?
On aortic regurgitation, is it likely or unlikely?
Unlikely. If unlikely, because they had developed this cyanosis later on. So
Yes,
if
yes.
VSD will close.
And also the aortic regurgitation. So the
They progress
possibility
very
of
fast. So they develop severe AR within second decade, and
Yes.
if they don't treat it, they will have very poor prognosis.
Yes, usually the aortic regurgitation occurs before the age of 12, and by the time they can progress to significant aortic regurgitation if it is to progress. And so this patient that did not happen, so I would consider that aortic regurgitation is unlikely. What about the Eisenmenger, PH Eisenmenger?
So he has developed cyanosis. Is it likely to be RVOT obstruction or Eisenmenger? That's the issue in this case from the history. And that is what you have to do when you are examining.
That
Yes, what is it likely?
Sir, can it be a cyanotic TOF that changed to cyanotic later on?
Now that depends on at what age the patient developed cyanosis. If it is VSD. So that is the issue where sir was.
Why did you bring in a cyanotic TOF?
Sir, one of the differential, because I was thinking maybe any other differential diagnosis possible here or
But
not.
usually the cyanotic TOF also will be very symptomatic. When these patients run, play, and all those things, what will happen?
Yes, sir, they can develop.
They develop immediately right and left shunt, they develop cyanosis, and they become symptomatic. So that is why I always teach my students that if the patient is having having a clinical finding which you think is a small VSD, and the patient is unusually symptomatic, we should think of pink fallow. Because in pink fallow, when they exercise, immediately there is a right left shunt and the patient becomes grossly symptomatic. So even though the child may not be cyanotic, but they will be quite symptomatic. And these children are really symptomatic because they can play about, run about, and they become significantly symptomatic. So pink fallow.
So the issue here is, sir, there is this patient has developed cyanosis, right to left shunt. Is it because of it indicates that the RV systolic pressure has gone above or it has gone to systemic level and resistance has gone up? Is the resistance at the arteriolar level or at the RVOT level? So there it is useful your maternal history. Now there is the obstetric history. So which is likely to be tolerated? The patient is developing a large VSD. The patient has developed some degree of RVOT obstruction. So the heart failure has increased. The RVOT obstruction has progressively increased. And they develop right to left shunt clinically by the age of 35 years. And she tolerated 2 pregnancies without much problem, which is likely to be more with Eisenmenger or with a Gisol VSD. Which is, I will not say, which is the worst thing.
Eisenmenger, you consider it as a favorable lesion for pregnancy, or you think that it's a contraindication for pregnancy?
Contraindication. It is a contraindication because it is a severe pH. The maternal mortality almost 50% with Eisenmenger, so it is a contraindication.
So I think for the of these 2 lesions, for as far as the pregnancy is concerned, the RV outflow obstruction is more favorable than the development of pulmonary arterial hypertension, Eisenmenger syndrome. No,
so that is the way I look at this case. There is a patient has developed right to left shunt. It might have occurred earlier. They have detected only by the age of 35 years. So they might not detect, say, to detect clinically cyanosis, the oxygen saturation has to be less than 85%. So it could have been 2 things. One, an Eisenmenger syndrome. Occasionally, they may tolerate the pregnancy and or development of a gradually progressive RVOT obstruction, which has resulted in a severe RVOT obstruction mimicking tetralogy of Fallot now. So our clinical examination should be oriented to differentiate that is Eisenmenger syndrome or a tetralogy of Fallot situation, that is Gisol VSD. That should be our target in examination. Because Arun is looking at us because it is almost 30 minutes. We have to discuss the physical findings also.
Should we go beyond VSD? Should we think of ASD? Or do you think that you should consider Epstein's anomaly also in this patient?
Epstein can present like this also. So Epstein can present like any CSD.
No, you can put it like this. All these are possibilities, but Epstein's anomaly presenting with deep cyanosis requiring phlebotomy at this age group is very unlikely. There will have cyanosis from early period.
No,
let us discuss that point.
What is the
adulthood? Epstein usually they present with arrhythmias, so they have
not that. The available point, Epstein, if it is a cyanotic Epstein, they present with cyanosis early. Here, now the patient has deep cyanosis requiring phlebotomy. That is very unlikely as my information is concerned. They present at this age group with more of heart failure and arrhythmias. So that, I think, what Sir said to us, we have to discuss all the points. But I think Sir's question is, can it be AHD?
No, ASD and also I think Epstein, I thought Epstein also should be discussed. Epstein, especially patients with some, not only the atrialization of the ventricle, if there is an abnormality of the tricuspid valve, sometimes patients with Epstein's anomaly can present with significant cyanosis. And what is the pattern of cyanosis in Epstein's anomaly? Can you just quickly say? What is the pattern?
Clear, but you should say triphasic mechanism.
What is the mechanism of cyanosis in Epstein's anomaly?
Yes, Dr. Harjap.
Can they be cyanosed at birth?
Yes, it can.
What is the mechanism?
Because blood is not going enough into the pulmonary circulation.
And not that. No, that is not enough. Cyanosis.
Right to left shunt from the
Right to left.
PFOs.
At
Yeah,
what
this is
level?
In these patients with Epstein's anomaly, at birth, since the pulmonary vascular resistance is high, there can be a significant tricuspid regurgitation. The RV has to pump blood into the pulmonary circulation, and since the vascular resistance is initially high, there can be significant tricuspid regurgitation, and if there is a atrial septal defect, there can be left to right shunt. This is only for a short. Right to left shunt. This is only for a short period. Immediately the pulmonary vascular resistance drops and the tricuspid regurgitation comes down and the cyanosis disappears. So initially there can be cyanosis for a short period and the cyanosis disappears as soon as the pulmonary vascular resistance comes down. And then at a later date, they can develop cyanosis again. Then what is the mechanism?
RA pressure has to go up.
What is the mechanism?
RA pressure has to go up. This is a clue.
Atrial enlargement and increased RA pressures.
Which one?
Right atrial enlargement, sir.
Right atrial enlargement, how can it give rise to RA pressure elevation? Sudhaivan has given you a clue. RA diastolic pressure, RA pressure is depending upon what pressure? Left ventricular pressure, right ventricular pressure?
RA pressure is equal to but tricuspid valve is open.
RV.
So RA pressure is equal to
RV.
Diastolic pressure.
Diastolic pressure.
Okay.
RV diastolic pressure. When the tricuspid valve is open, so how can the RV pressure go up?
Because sir, in Epstein normally the right atrium, the part of ventricle also gets atrialized. So RV is also hypoplastic in mostly in Epstein normally. So the RV.
Ventricular dependence, ventricular dependence.
No, you need not complicate the issue. RV fails.
These patients can develop again right to left shunt when the RV fails. When there is a failure of the RV open, RV diastolic pressure goes up, the right atrial pressure goes up, there will be a right to left shunt, and the patients can develop cyanosis again. So patients with Epstein's anomaly can have cyanosis at birth. They can immediately recover from cyanosis, and at a later date, when the patient develops RV failure, they can go develop cyanosis again. So I'm just asking, can that be applied to this patient? Because one thing which made me think that may not be VST is that usually a pediatrician or a doctor picks up in a heart lesion in a child where there is a loud murmur. VSD will give rise to a big murmur. So that is usually picked up by the pediatrician or by the doctor who examines the baby. But so in this patient, the very loud murmur is a bit unlikely according to me. So that is why I thought an ASD or even an Epstein's anomaly may be brought into discussion.
So Dr. Arun has given a message. Time to move on to the next parts. Okay. And one point, Dr. Arun, I want to discuss is from the chat talk, there was a answer that PVR is rising for this thing. PVR doesn't rise in Epstein's. It is a low resistance circuit. Only rarely you can have. The PVR is a low resistance. Epstein is a low PVR resistant system. The pulmonary blood flow is low. So that I want to correct because we should entertain the people giving their remarks. We have to teach them also. So that is basically why you have to think.
Yes. Yes, sir.
Yes.
So I was. That's what I was. That is why I was telling that after birth, we very quickly the pulmonary vascular resistance
comes down.
The pulmonary artery pressure comes down. The tricuspid regurgitation comes down. The right left shunt disappears. So there is a normal regression of the pulmonary vascular resistance.
So shall we conclude from the history that history of heart failure in the early childhood, symptom-free period for a long time, developing cyanosis later. It is a left-right shunt which has developed pulmonary right ventricular hypertension, systolic hypertension, because of either an obstruction at the pulmonary arteriolar level or obstruction to the right ventricular outflow tract, which has resulted in right to left shunt. So we think that statistically a pulmonary Eisenmenger syndrome, or if a BSD, a Gussul BSD, or low in the list, as sir said, they have to entertain ASD because the age at which it was diagnosed, which is not favoring BSD. BSD, they develop problems quite early. So that's the reason why sir was entertaining ASD also and Epstein's. Shall we go to the physical finding because Arun is restless?
Yes, okay.
Sir, can I proceed to examination part?
Yeah. I think the
Only solid points. You can just tell
Srinagar people.
relevant points.
Okay,
You need not to go to all those things. Relevant points, general examination, all those things.
I would like to still consider that as a low in the list, ASD should be brought in as a differential diagnosis. And Epstein's normally still lower in the list because of the.
So four things we said.
Okay,
VSD,
right.
then ASD,
No, just
Epstein's.
one more point I want to say that it's a far-fetched one. Whether this patient had BSD as well as ASD, and the BSD got closed after the initial period. Whether the BSD closed and the ASD started manifesting at the later age in life.
Okay, sir. Findings, just only the relevant things because we are running short of time.
Yes, okay.
In general physical examination,
okay, general examination, only the relevant things.
So the
positive things.
So she was having thoracic spine scoliosis. She was having cyanosis, which was uniform central cyanosis and involving pan-digital. It was pan-digital, and saturation was 84% at rest and decreases to 74% only. She walks few steps, and there was clubbing grade 2, sir. Pan-digital in R4.
Okay, fine. Next, pulse.
So her blood pulse rate was
the pulse, blood pressure.
Just one clarification I want to ask. Did the mother give a history of squatting in this patient at any time of life?
He said no. In the history, he mentioned that, sir. There was no change with posture.
I didn't see that.
No, sir. There was no history of this.
No history of squatting. Okay. Right.
No, sir. Squatting, there was no history, sir.
Okay. Then presentation, it should be pulse, blood pressure, respiration, oxygen saturation, then JVP. Okay, that should be the pattern for MBBS, MD, and DM. Okay. Next slide.
So, actually, I teach students saying that the cardiovascular examination can be extra precordial examination and precordial examination, and the extra precordial pulse, blood pressure, and JVP should be separately discussed. And then you can go to the precordial examination where there can be pulse, the inspection and palpation can go together, percussion, auscultation subsequently.
So next pulse.
The positive
next slide.
Dr. Hajab, pulse blood pressure.
Pulse
next
was
slide. Pulse.
676 beats per minute, regular, normal character, good volume pulse, equal on both sides.
It is normal. Pulse is normal.
Only
blood
positive
pressure?
findings was blood pressure was also normal.
No, we say that pulse is normal, blood pressure is normal. There is no anisospasmia. That is the way. When you are presenting as a short case or summarizing, because we are running short of time, the patient is having the regular pulse normal. Then blood okay, change that. The blood pressure 130/70 with a little white pulse pressure. Then respiration is normal, oxygen. Now JVP.
JVP on sitting position, it was not raised at 45 degrees, sir. It was 3 mm above the sternal angle, and waves were normal waves were seen. And abdominal jugular reflex JVP was not persistently elevated, and it was elevated less than 3 centimeter rise was there.
So if the JVP is only elevated,
confuse that.
Yes, sir.
Don't confuse that. Jugular venous pressure. Don't beat around the bush and invite questions because JP is a difficult area. Get away from JP at the earliest. Jugular venous pressure is not visible in the sitting position. That's all what is needed at your level. And you have to say abdominal jugular reflex is normal, not negative. Okay. Then you have to talk about the waveform.
What about waves?
That is very important at your level.
No, if you want to
pressure is
in a patient where when the sitting posture, if the jugular venous pressure column is not seen, I think if you want to study the wave column, you can put the patient in 45 degrees. Definitely, it will help you to look at the wave pattern. Especially if you want to comment about the wave pattern, put the patient in 45 degrees and observe again whether the venous column is seen and whether you can delineate A wave, V wave, and any abnormal wave pattern is seen or not. I think that will also help you to come to proper diagnosis. But as he said, JVP, you should not linger on JVP because if you linger on JVP, examiner will sit on you. So it is better to
don't use that. It is not persistently elevated and less than 3 centimeter rise. Don't put it like jugular venous pressure is not elevated. This is a normal waveform. Then how did you say that? I put the patient in 45 degree. Don't measure in 45 degree. Okay, abdominal reflux is normal, not negative. That's all what is needed. Am I right, sir?
Yeah, abdominal
Normal waveform. Okay.
there is nothing like negative abdominal. There is nothing like the upper abdominal compression giving rise to an abdominal response. It's a normal response, as you rightly pointed out. Okay.
It is reflux is reflux. That is very important. It is not a reflex. It is reflux, flux, not reflex.
No
Very
reflex.
important. Negative means there is an IVC obstruction because the venous return cannot be sent to the right atrium. Next slide.
What about wave pattern? It will say. Dr. Harjab, what is the wave pattern?
So in this patient, wave patterns were normal, sir.
Okay.
They were no.
Okay, go ahead.
Question. I could not get the question. What was the question?
What is the waveform? What about the waveform?
Oh, okay. So you can comment about the waveform. If you at 45 degrees, you said it is elevated 3 centimeters into the neck, and then you can, if you want, you can make a comment. So, but you said it is a normal waveform.
Possibly, yeah. You could not.
Yes. Okay.
Go ahead.
Okay.
Positive finding.
If at all you are looking for what wave can be seen in the neck.
A wave can be prominent in patient who is having Eisenmenger, sir.
Yeah, in which Eisenmenger you will have more likelihood of a prominent A wave?
ASD Eisenmenger. ASD Eisenmenger.
Yes, ASD Eisenmenger, because ASD is
they are more this suprasystemic.
Yeah, you can do the pressure can be suprasystemic, and you can get a wave in the neck. Of course, it is very uncommon in VSD and PDA, but sometimes you can get in ASD. Okay, yes.
Here the point we just a quick, don't bother very much as ellipsoid and all those things because I am not happy. I don't know whether we'll call it as ellipsoid. The chest is symmetric. The next thing is I think it is an unintentional error. Apex beat is visible in the fourth and fifth parasternal area. That I think is not.
So it was a diffuse type of
What we do is we combine. Sir, chest is symmetric. There is no precordial deformity or dilated veins. The apex beat is seen and felt. Then you go to palpation.
Actually, you in inspection you cannot comment about the apex beat. Can you define apex beat? Define apex beat. Define apex beat. Define apex.
What is the
outermost and lowermost?
Outermost and lowermost.
Lowermost part of
the precordial.
Definite cardiac, uppermost and lowermost point or definite cardiac impulse, which is either seen or felt, both. It should be the lowermost and outermost point where a definite cardiac impulse is either seen or felt. So in inspection, you cannot use the word apex beat at all. If you want to use it, you should combine inspection with palpation.
At postgraduate level, what we do is we combine this and make it very brief to the point. So chest is symmetric. There are no dilated veins or scar. Sir, the precordium is active. Okay, there are prominent pulsation visible. You can say there are prominent epigastric pulsation second space. Then apex beat is seen and felt. So go to the next page. Palpation.
Visible pulsation over this left second intercostal space. So what does that mean? Does that favor already the differential diagnosis we have been thinking about? Which one favor? Is it favoring an Eisenmenger or is it favoring Guzol VSD?
The most important thing in congenital heart disease is the pulmonary artery, anatomy and physiology.
So if the pulsations are felt and seen and also felt in the pulmonary artery pulsations are felt, will it favor pulmonary artery hypertension or a RV outflow obstruction?
Pulmonary artery hypertension.
Pulmonary artery hypertension. Okay, yes, okay.
Here again you have a problem. Apex beat present in the fourth and left intercostal space in parasternal area. No. You have to say which space, where medial to mid-clavicular, intermid-clavicular, lateral, and you can say it is an RV or LV type at postgraduate level. Then left parasternal lift not sustained.
So he has in the palpation, he has described apex beat present in the left, palpated in the left, fourth and fifth. Apex beat is felt
in the
fourth.
parasternal area.
No, but it's meant by fourth and fifth in the apex beat how can it be felt in the fourth and fifth? Apex beat is defined as the lowermost and outermost point where a definite cardiac impulse is felt or seen. It cannot be in two intercostal spaces. Wrong.
So you have to put it like this: in the fifth left intercostal space, medial to mid-clavicular and lateral, and is it RV type or not, or LV type, if you are sure. Then there is a left parasternal lift not sustained. And parasternal lift is enough, synchronous with the apex, or you put the other way, the apex is synchronous with the parasternal lift, indicating that it is RV type. There are systolic pulses in the second left intercostal space.
One more point I would like to get the opinion from the student. If you want to make a comment whether it's RV type or LV type, you must also make a comment whether the apex beat is continuous with the parasternal pulsations. If the apex beat is continuous with the parasternal pulsation, that is an additional point for you to think that most likely the apex beat is formed by the right ventricle. So you must always look at the parasternal pulsations. When you look at the parasternal pulsations, you can make out whether the parasternal pulsations are continuous with the apex beat, and you can make a comment also. Okay. So here, did you think that the apex beat is formed by the right ventricle or by the left ventricle?
Right ventricle. Right ventricles.
So then you should have made a comment that the apex beat is continuous with the parasternal pulsations. That is the way in which you can make out whether it is a right ventricular apex or a left ventricular apex. How will you make
some
out
RV type and LV type? I think the chat box, that's what sir has discussed. If the apex beat is localized and it is dysynchronous with the parasternal heave, it is LV type. If the apex is diffuse and synchronous with the parasternal heave, it is RV type. When it is an RV type of apex, the RV is usually enlarged. So the apex will be displaced. So in this case, it is extremely important to know what is the cardiac size. The location of the apex is very important because in our different diagnosis, that may be very useful. Then you have said there are systolic pulses in the second space suggesting pulmonary artery dilatation. So that we have excluded something like a Gazole VST. So far it is going for a pulmonary hypertension with cyanosis, Eisenmenger syndrome. So our aim should be to see whether it is VSD, PDA or ASD. That's the way we proceed each stepwise. It is not PDA because there is no differential desaturation. So now our point should be how to differentiate whether it is a simple, straightforward Eisenmenger VSD or ASD. We are not talking about the rare conditions. Okay. Is it likely to be, we have four things in our mind on Eisenmenger VSD, a Gazole VSD, Eisenmenger ASD, and Epstein's. Is it Epstein? So that is the way we proceed. When you auscultate a targeted auscultation. No, the pulmonary artery is dilated. The pulmonary artery is not dilated in Epstein's. It is a low flow group.
In Epstein's, where will you get the pulsations? In Epstein's anomaly, where will you get the pulsations?
They may not answer.
Where in which chamber can be dilated in Epstein's?
Are then right side of the stratum, sir, right.
Right of the
Sir is
stratum.
asking.
Which
Sir is asking about.
Where can you get the pulsations in a patient with Epstein's anomaly? Usually you can get the pulsations because of the RV outflow pulsations. And usually RV outflow pulsations are felt in the third left intercostal space. Can you tell me another condition where you can get prominent RV outflow pulsations without any RV body pulsations?
Where the right ventricle is small.
Where the right ventricle
is obliterated.
And the disease is gradually fading away.
The clue is there. RV is small, RV apex is obliterated because of fibrosis. You cannot give much better clue.
It is in RV endomyocardial fibrosis that you can get similar RV outflow pulsations. There are two. If you look at the RV pulsations, one RV pulsations can be RV outflow and RV body is not pulsatile. Two conditions are Epstein's anomaly and RV endomycal fibrosis. Two.
You got an answer from the audience. The chat box, they said RVMM. We should appreciate that.
Okay.
Auscultation. So now your auscultation is targeted to confirm that this is isomonger and try to separate VSD, PDE. Sorry, VSD, ASD.
Yeah. So I want to give an explanation about how to decide whether it is an RV apex or a biventricular involvement or an LV apex. What I usually do is that you palpate the apex beat and try to track medially. If the pulsations disappear and there are no pulsations in the parasternal region, the apex beat is formed by the left ventricle. Two, when you track medially, the apex beat merges with the parasternal pulsations, then the apex is formed by the right ventricle. Three, when you track medially, initially there is a disappearance of the pulsations, and as you come to the parasternal region, the pulsation becomes again more prominent. Yes. This is a biventricular involvement. Yeah. So by doing this, I have found that you can always definitely make out whether it is an RV apex beat, LV apex beat, or the patient is having a biventricular involvement. Okay, go ahead.
Shall we move to auscultation, sir?
Yes.
Auscultation. Percussion we'll skip. Auscultation.
Auscultation, sir, positive finding was as to a single and loud, there was loud T2 and intensity was maximum in the pulmonary area.
When it is single, it's not easy to say loud P2. Yes, okay, you say it is single and loud. You say single and loud. Yeah. Now the question whether it is P2, A2, all those things, it is not easy. My intensity, oh no, don't bother about that. So second sound, always we comment on pulmonary area. So first sound is normal, sir. Second is single and loud. And when you don't say no splitting, okay, but what is the no S3 or S4? What is the next thing which you have to look for in this case? Rather than no LV or RV, S3 or S4, no
failure.
Ejection click.
Ejection click.
No ejection click is the important thing. So we have to come to the case. Okay. So the first sound is normal. Second sound is single and loud. So there is no ejection click or other sounds like S3 or S4. Okay.
Why the ejection click is very important? What is the mechanism of production of ejection click, if at all it is there in this patient? What are the pulmonary ejection click? What are the two types of pulmonary click?
It decreases with inspiration.
Yeah, there are two mechanisms. One is a valvular click, other is a
vascular.
What is the difference between these two?
The valvular click decreases during inspiration, sir.
Oh.
Yes, sir. That's right, sir.
May decrease or even disappear during inspiration, and vascular click?
It remains the same.
It remains the same. What is the reason? Reason?
Because of
the why is
we are getting good answers in chat box.
Hangout interval. No, hangout interval is not the mechanism. Why? How can the ejection click be absent or decrease during inspiration? All the events on the pulmonary side increase on inspiration, and this is the only event which comes down during inspiration. What is the mechanism? What happens is that in these patients, pulmonary stenosis.
So we are getting good answers in the chat box for both. Good answers in the chat box for both mechanisms.
No, let me see. Okay. Oh, chat box.
Chat box, they are giving good answers. That is high vascular resistance and the doming, which occurs during inspiration. I think they have to read because phasic ejection click and constant ejection click. Phasic ejection click better heard during expiration. It's a right-sided event. It indicates domed pulmonary valve stenosis. Doming pulmonary valve, not dysplastic pulmonary valve.
Well, actually, during inspiration, when there is an increase in the venous return onto the right side of the heart, and the blood flows into the right ventricle. If the patient is having pulmonary stenosis, when more blood flows in the right ventricle, the right ventricular diastolic pressure goes up because it is a non-compliant right ventricle. And that the pressure in the right ventricle even may exceed the pressure in the pulmonary diastolic pressure. It can exceed the pulmonary artery diastolic pressure, resulting in actually there can be opening of the pulmonary valve and the blood can flow from the right ventricle into the pulmonary artery in the late phase of the diastole. Because of that, there is no more further opening of the pulmonary valve and the click completely disappears. But this does not happen in a patient with severe pulmonary arterial hypertension, vascular click, where the click is present during inspiration as well as during expiration. So in a patient with pulmonary click, the click secondary to pulmonary stenosis can be phasic, while patients having a click because of the pulmonary arterial hypertension and dilatation of the pulmonary artery will be a constant ejection click. So click is very important.
Dr. Arun is putting, we can probably move on to diagnosis and investigations in brief.
Okay, we'll go ahead.
Okay. So that murmur, early diastolic murmur, which is the pulmonary regurgitation murmur, and you are getting a TR murmur also. Okay, fine. So what is your diagnosis?
So is it early diastolic murmur?
Yes.
Well, is it associated with a thrill?
He didn't say that.
It was not associated.
There you have confused
Early
us.
diastolic murmur, do you think it is a pulmonary regurgitation or a aortic regurgitation?
He has confused us himself.
In adult, whenever you are hearing an early diastolic murmur, I will not jump to pulmonary regurgitation. I would still like to think whether it could be aortic regurgitation. Is the murmur audible on the right side of the sternum?
No, it was on left side.
What was the blood pressure? What was the blood pressure? What was the pulse pressure?
You said there
was 60 millimeters. It was 60 millimeters pulse pressure.
So,
but basically, you are looking at the background case and you are localizing the EDM in the second space. Statistically, you can say it is likely to be pulmonary regurgitation because you have diagnosed pulmonary hypertension. But the problem was best heard with patients sitting up and leaning forward. That is only for AR, not for PR.
Not for PR.
Doesn't change. So that you confused yourself.
And not only that, so if you go by statistics, I think aortic regurgitation is much more frequent than pulmonary regurgitation, especially she is around the age of 60.
Sir, I said statistics in this case because he has documented severe pulmonary hypertension Eisenmenger. So
no, he has not documented. He has not documented. Sir, he said the second sound is loud. That's all.
Second sound is loud. Pulmonary artery is dilated.
And
we have said that it is Eisenmenger, not Gazole VSD. So we have come up to that level. In such a case, if you get an EDM, it will be pulmonary regurgitation. That's only statistics which I said, not general statistics. There you confused because it is a localized murmur at the second intercourse space, but sitting up, leaning forward, inspiration. This doesn't tally.
But one
sitting
thing,
up, leaning forward, inspiration doesn't tally. That's not the usual presentation.
And also the pulmonary regurgitation murmur, hypertensive pulmonary regurgitation murmur, very often may be associated with a thrill because it's a very superficial murmur, and very often it may be associated with a thrill, which is not a feature of aortic regurgitation. And also this patient, when you took the blood pressure, you said that there is a white pulse pressure. So is there a possibility of aortic regurgitation causing this early diastolic murmur? And you also described the murmur louder, sitting up, leaning forward and all. So I think you have to keep your mind open and discuss both the possibilities. Okay, go ahead.
But the finding is not compatible. Sitting up, leaning forward, inspiration. That doesn't tally. So there you didn't apply your basic knowledge. I don't know why you put sitting up, leaning forward is only for AR. Pulmonary regurgitation, we don't do that. It is in supine position. And in severe pulmonary hypertension, doesn't change with respiration also. Forget about that. But because Arun is very restless. Sir, Arun is very restless.
But he's doing the examination in the sitting up and leaning forward position. I thought it was correct because he has to differentiate whether it is an aortic regurgitation murmur or a pulmonary regurgitation murmur in a woman, in a person who is 60 years of age.
I agree with you, sir. But he is saying that it is best heard sitting up, leaning forward during inspiration. That is entirely.
Okay, right.
That is the thing which I was highlighting. That is,
Actually, in
there is a-
aortic regurgitation, Dr. Singh, is it the murmur is better audible during inspiration or expiration?
Is more on inspiration, sir.
More?
Yeah.
Aortic regurgitation murmur. When you do the auscultation, you make the patient sitting up, leaning forwards, and breath held in what? Inspiration.
Full expiration.
Expiration.
In
There is an
in
expiration.
expiration. You have
So that was
described
not
it.
compatible. That's the point which I want to highlight.
No, actually,
Okay.
second thing,
Then you have the
your description that see the hemodynamics of pulmonary regurgitation is entirely different from hemodynamics of tricuspid regurgitation. The pulmonary regurgitation murmur need not always increase on inspiration. There are a lot of hemodynamic changes. There is no time to discuss that. The hemodynamics of pulmonary regurgitation murmur is entirely different from tricuspid regurgitation murmur. So you cannot immediately take it as that it will increase on inspiration.
that
Okay,
I
go
will
ahead.
give you as homework. Pulmonary regurgitation murmur, hypertensive, normotensive. That you do the homework. Okay. Shall we go to the diagnosis, sir?
Yes, yes.
What is your diagnosis?
The diagnosis.
Diagnosis.
Yes, sir. Cytosolitis levocardia, post-tricuspid shunt, and decreased pulmonary flow with pulmonary artery and likely VSD with Eisenmenger, sir, with no signs of heart failure, no infective endocarditis, sinus rhythm, and HFOR, sir.
Then the only thing is decreased pulmonary blood flow with PAH. Now
Yes.
you have to defend that. You have to defend because basically this is a post-tricuspid shunt. Now simple thing will be, sir, a post-tricuspid shunt with severe PAH Eisenmenger syndrome, most likely VSD.
Yes.
That is the way you have to put. Because decreased flow with pH. Can you explain that? Is it basically a high flow, low flow, or normal flow? There the problem comes. You have to discuss that. Eisenmenger syndrome, is it a high flow group or a low flow group?
Low flow, sir.
The pulmonary blood flow is likely. So that creates, invites more questions to your side.
No, you
So
see, it is sometimes it is extremely difficult. Very often in a patient with Eisenmenger, it is a bidirectional shunt.
Yeah.
So you cannot immediately say as the decreased pulmonary blood flow. So it's
So that's a
mostly
problem. That's what I want to highlight.
because it is a bidirectional shunt, patient becomes cyanotic, but you cannot immediately make a statement that it is a decreased pulmonary blood flow situation.
The problem will be you will be cornered for bidirectional shunt. What is the QP by QS? Effective, all those things will come. So safer will be okay, cytosolitis levocardia, congenital heart disease, post-tricuspid shunt with severe PAH. Now right to left shunt,
You can use Eisenmenger syndrome.
Eisenmenger syndrome, straightforward,
Yes.
and most likely ventricular septal defect with pulmonary regurgitation, tricuspid regurgitation. So that we have to tell. You have to have a comprehensive statement. That is congenital heart disease, Eisenmenger syndrome, most likely ventricular septal defect with pulmonary regurgitation, tricuspid regurgitation, sinus rhythm, not in heart failure, NYHA4. Okay.
Is the murmur audible down along the parasternal region? Is the murmur audible at the apex, the early diastolic murmur? Doctor, is the early diastolic murmur in this patient, was it audible at the apex?
Sir, it was not.
Okay.
Dr. Harjab, did you listen to my apex?
Yes, sir.
EDM.
It was not audible at apex, sir.
Is it audible at the apex?
No, sir, it was not audible at apex.
Is it was it audible on the right side of the sternum?
No, sir, no, not on right side of the sternum.
Not from, okay. No, but because in an adult, I would still consider, I would like to rule out aortic regurgitation because of the fact that she has got a wide pulse pressure and she's 60 years of age. And in this very often hypertensive PR is associated with a thrill. This patient is not having any thrill at all. So all put together, I would like to still keep the possibility of aortic regurgitation. Of course, in a patient with severe PH, it is easy to diagnose. It is easy to define pulmonary regurgitation than aortic regurgitation. Okay, yes, go
First
ahead.
point is this patient by echocardiogram invariably will have pulmonary regurgitation, Doppler wise. So sir is telling there may be an associated AR also. That is sir's point. Because statistically, if you take the usual thing, AR is more frequent than PR. But with the background, the patient is likely to have PR. Definitely, he will have PR on echocardiogram. And sir, what he's telling is look for an associated AR also. Okay. Shall we go to the investigation, sir?
Okay, yes, yes. ECG, X-ray. Do you want to discuss possibility of ASD also in this case? Eisenmenger ASD?
Yes. For sir's question, you can take it how to differentiate between ASD and VSD Eisenmenger. What are the important points?
Rating of second heart sound was
Yes.
No, cardiomegaly.
cardiomegaly splitting of second heart sound, and parasternally will be more prominent in ASD. They also have cardiomegaly as well.
Yeah.
And also ejection clip,
Cardiomegaly.
everything is flowing.
Splitting of second heart sound they will have.
Of course, yeah. When these patients have developed, the Eisenmenger syndrome, usually heart size can come down because the heart size is decided by the extent of shunt. So in a patient with ASD, BSD, or PDA, when they have started developing Eisenmenger syndrome, the shunt comes down, and gradually the heart size can become normal or may not be hugely dilated. So patients with ASD with Eisenmenger also sometimes can have a normal sized heart. But I agree with you that if the heart is large and if the patient is blue and if there is Eisenmenger findings, that will be more in favor of ASD than VSD.
Okay, go ahead with the investigation. Dr. Rajab, it is getting late.
Yeah, okay, go ahead.
Relatively, ASD has a larger heart. White split persists in 80%, and the pulmonary regurgitation murmur will be more impressive or louder and long. Yes. You want the ECG?
Sir, I will go with the ECG. It is a 12 lead ECG with paper speed of 25 mm per second, which is standard speed with the.
You come to the conclusions.
Okay, get to the point. What are the things you look for?
So in this patient, he is having positive point was, sir, he was having, sir, R more than S in V1, and
okay, there is right ventricular hypertrophy.
Yes, RVH,
okay.
features of RVH.
But what is more important? What is more important? Axis. You have to look at the axis to know what is the type of. So he is the right axis. Basically, rhythm is sinus, right axis, and RV dominance.
In this patient, what in this electrocardiogram, what are the features which suggest to you that there is a right ventricular hypertrophy?
Presence of in V1 R more than S. If it is more than S, it is suggestive for RVH with right axis deviation. With if presence of ST depression in V1 to V3 also, they also signify the strain RVH with strain.
Anything else?
And RS ratio in V.
Anything else?
Less than 1.
And yes.
Usually, when you look at right ventricular hypertrophy pattern, you look at three ECG findings. One is right axis deviation. Second is the pattern in the V1 where the R wave is taller than the S wave. And also in V6, you look at the R by S ratio where it is less than 1. Here it is R by S ratio is less than 1. So it has got all the three features. The right axis deviation, all the three features are there. So when you look at the right ventricular hypertrophy, you look at the axis, you look at the R by S ratio in V1, and also you look at the R by S ratio in V6. Well, can you tell me one
V6 is more sensitive and specific. Yes.
And can you tell me one situation where R by S ratio in V1 can be less than 1, while in V6 it can be less than 1, and that indicates right ventricular hypertrophy. One clinical situation where when you take the electrocardiogram, R by S ratio in V1 is less than 1, and our R by S ratio in V6 will be less than 1. Sometimes in COPD, sometimes in patients with COPD, where you can sometimes get R by S ratio in V1 can be less than 1, and R by S ratio in V6 will be less than 1, and that the second criteria will apply, and patients can be diagnosed with right ventricular hypertrophy. So sometimes in patients with Eisenmenger, not Eisenmenger, patients with COPD with a core pulmonale, you can get this pattern where R by S ratio in V1 is less than 1 and R by S ratio in V6 is less than 1, and then also you can diagnose right ventricular hypertrophy. Okay,
Go ahead.
go ahead.
X-ray, X-ray.
Sir, this is X-ray. This is PA view of the X-ray, just showing, sir, scoliosis of the spine, sir.
Forget about that. To the point. To the
And
point.
there is RV type of apex with the dilated right pulmonary artery and main pulmonary artery.
When there is a chest
dilated, the RA
deformity,
enlargement also.
when there
Yes,
is
sir.
a chest deformity, don't make finer aspects of decision like RV apex or LV apex. When there is a chest deformity. Okay, fine.
Right pulmonary
So,
artery.
if you look at the X-ray of this patient, do you think that it is more likely to be VSD, ASD?
Sir, it is looking cardiomegaly, but RV apex is upturned, sir. Cardiomegaly is there.
No,
but
in
because
RV
of,
apex,
because of scoliosis, they can have increased CTR, no, sir.
Does the RV apex help you to differentiate between ASD and VSD?
Cardio, on the basis of cardiomegaly, we can differentiate. One and dilated are more common.
What about the right atrial enlargement?
Right atrial enlargement goes with ASD.
Chest deformity, RA enlargement, you can't make out from X-ray.
Yes, sir.
In a normal question, this thing, the criteria are there. But you can say, sir, there is definitely dilated pulmonary artery, dilated right pulmonary artery with peripheral pruning that goes with our diagnosis of Eisenmenger syndrome.
Eisenmenger, yes, sir.
In an Eisenmenger X-ray, if you see that there is a prominent aorta, that goes more in favor of PDA. If you get a right atrium is enlarged, that goes more in favor of ASD. And if both are not there, that goes more in favor of VSD. It is not applied, it's not 100%, but this is the way you can think about, that's all. So aorta, PDA, right atrium, ASD, and neither goes more in favor of VSD. And which one will have more end-on vessels? If you think that
larger shunts are seen with
end-on vessels more common
in which ASD, VSD, PDA, which one will have more end-on vessels?
Original discussion, we said that large shunt is seen with ASD.
ASD.
So,
end-on vessel is with ASD.
Yes, larger number of end-on vessels are seen with ASD. So if you are seeing plenty of end-on vessels, I think that is also an additional point for you to think that it could be ASD. In VSD and PDA, because of the early reversal of the shunt, and the shunt is not that torrential, the end-on vessels are not that much. So plenty of end-on vessels in the X-ray chest will make you think that it could be an ASD Eisenmenger. Okay, right, go ahead.
So 1 minute, you look for PDA calcification, which is diagnostic.
Yes, yes.
You
yes.
look for
If it is there,
calcification
yes.
of the PDA. That is almost diagnostic. That you have to look for. Okay, next.
Where do you see PDA calcification? Where do you see the PDA calcification? You can see as a parallel line from the pulmonary artery segment, near about the pulmonary artery segment to in the direction of the aorta. You can actually see it very clearly. And PDA calcification is a point in favor of or almost diagnostic of PDA Eisenmenger. Okay, go ahead. But it is not very frequent. That's the only thing. Echo.
Okay, echo quick.
Sir, echo first is for showing cytosolitis levocardia, sir, and then
cytosolitis. Cytosolitis so far. Yes.
Yes, sir.
Go ahead.
Then, sir, this on fourth this parasternal long axis view, it was showing there will be a this because previous slide.
There is a large VSD with the right direction.
Yes, sir.
Right direction.
Okay. And shunt was bidirectional, sir.
Okay, fine.
Most of the times in Eisenmenger, it is bidirectional.
Yes, sir.
It is almost always bidirectional. It's very rare that it is right to left only. It is very often it is bidirectional. Okay, yes.
You have to look at the location of the VSD. Location of the VSD. It's a large perimembranous subbiotic VSD.
Yes, sir.
Okay. Fine. Next slide.
So there is septal flattening, likely feature of pulmonary artery hypertension, sir.
I'm not very convinced that flattening occurs when there is pH with RV dilatation. I'm not fully convinced with the septal flattening. Next slide.
No, there is no, I don't agree with that because it is septal flattening because you are expecting a near about D sign, but here it is LV is not D shaped. So I don't think that you can consider septal flattening as a finding in this patient.
Septal flattening occurs when there is an associated RV dilatation also. So you have been taught that septal flattening indicates pH need not be there. Here it is not there. But we are interested in so many other things.
How will you differentiate whether it is septal flattening is due to volume overload or whether it is due to pH? How will you differentiate? How will you differentiate? Where Sudhimar pointed out that it can be a volume overload also. If there is a volume overload or the RV, there can be some degree of septal flattening. But how will you differentiate between these two?
So classically, when there is pulmonary with RV dilatation.
If the flattening persists even during systole, that will be highly suggestive of pH. Because if it is the flattening is present during diastole as well as systole, it will be pH. Okay, go ahead.
Next slide. Next slide. Next one, because this
IVC was on 21 centimeter, and on inspection it gains to
that's
1.
not important. We come to the important thing, hemodynamics. Okay.
So then,
what is this?
Sir, and he was having, sir, PR. Peak PR was 4 velocity, and PR was 3 meter per second, sir.
So there is severe pH.
Yes, sir.
The pulmonary early gradient is 64, and end-diastolic gradient is 3 raised to 36 or 40. Okay, fine.
Say the early diastolic pulmonary regurgitation gradient, it represents what?
This pulmonary mean pulmonary artery pressure.
Yes, very it good. Is mean pulmonary artery pressure. And gradient?
So diastolic pulmonary artery pressure.
Diastolic pressure. Okay.
Okay, good.
Yes.
Next.
So this is the size. It was 1.8 centimeter size, sir. VSD, sir.
Forget about that. We come to the TR.
To the TR.
So on the left side, it was showing, sir, TAPSI was around 18, and TR was, sir, RVSV 70 plus RAP, sir.
So basically, what you have to do is when you are looking at the echocardiogram, important points are you should highlight. Okay, IVC not in the initial part. TAPSI not now. We are interested in the anatomical, it's a large VSD. What is the type of VSD, or embryologically or whatever anatomically, what is the type of VSD? Second is you can try to see whether it is a left-right, bidirectional, or all those things. But we are interested more in the pulmonary vascular resistance, pulmonary artery pressures, all those things. So you should come to PRJet and this thing well ahead of IVC. So IVC, we are not very much interested in IVC because the JVP is normal. So we are not expecting an IVC. The RV function is normal. So here we are mainly interested in the RV pressure. For what? Because our different diagnosis. Is it ASD or VSD? How to differentiate from the RV pressure? I think you have to answer that. RV pressure is dash in VSD. It can be RV pressure is systemic in VSD. It can be suprasystemic in ASD. That's the thing which you have to look into. Okay, these are the hemodynamics which you should know.
But very often you don't get a suprasystemic pressure in ASD also, even though theoretically, if there is a suprasystemic pressure, that is definitely ASD. But of course, here you have already demonstrated large VSD, so that question does not arise in this patient. Is the patient having aortic regurgitation? I would like to know that. Have you looked for aortic regurgitation?
So she was not having aortic regurgitation. We have looked at it.
Probably they might not have concentrated on that, sir.
Because in a patient, whenever there is an early diastolic murmur, because of the aortic regurgitation is much more frequent than all the other two. What are the other two conditions where you can get early diastolic murmur? One is aortic regurgitation, other?
Pulmonary regurgitation. Third one?
It
is not pulmonary, it is not aortic. There are no two great arteries. There is only one great artery.
Truncal regurgitation. So whenever you are hearing a early diastolic murmur, you have to fix it whether it is a aortic regurgitation, pulmonary regurgitation, or truncal regurgitation. Even though some people say that there is something known as a dog's murmur, where it is a stenosis of the proximal part of the LAD sometimes can give rise to an early diastolic murmur, but I never heard it. So these three are the early diastolic murmurs: aortic regurgitation, pulmonary regurgitation, and truncal regurgitation. Okay, right? Yes. Go ahead.
And Hilal sir is smiling because after giving the clues. Okay.
Go ahead. Go ahead.
Yes, that's also. What is your diagnosis now? It's a confirmed large VSD Eisenmenger syndrome. Now the next question will be, how will you manage? Will you proceed with further investigations? Any further investigation needed or not?
How will you find out whether this patient is having reversible pulmonary arterial hypertension? And what is the level to which the pulmonary artery pressure should fall before you say that it is reversible?
90%. More than
What is the level to which it should fall?
20%.
Eh?
20%.
20%? No.
Where? On echo? On echo, you want 20% fall on echo or what?
No,
How do you want to get it out?
By the hemodynamic data, how will you assess whether it is a reversible or reversible pulmonary arterial hypertension? What is the agent that you use? What is the most ideal agent? What is the agent that you use? And what is the most ideal agent?
How do you do vasoreactivity testing?
Nitric oxide is the most ideal agent. You can use oxygen also, but nitric oxide is the most ideal agent. What should be the fall in pulmonary artery pressure, and what should be the level to which it should fall?
Yes, Dr. Harjap, you might have read.
What is the level to which it should fall?
How much should be the fall in mean pulmonary artery pressure?
The pulmonary artery pressure should fall at least 10 millimeters of mercury, and the absolute value should be less than 40 millimeters. So mean pulmonary artery pressure should be less than 40 millimeters of mercury. Then only you can call it as a good response. So I will repeat: the fall in the pulmonary vascular resistance should be, mean pressure should fall at least by 10 millimeters of mercury, and the fall should come below 40 millimeters.
40 millimeters mean pulmonary.
Then only you can say there is a positive response. So
I think you have to read the, circulation or ESC, where they have given the cutoff points for these things. And the most important, as sir suggested, the pulmonary vascular resistance should fall. And you will be asked questions on the diastolic pulmonary gradient, transpulmonary gradient, all those things you have to look into in evaluating reversibility rather than on a single value. Rather than on a single value, you have to look into all the parameters, and the PVR should fall, and that calculation based on the other gradients.
And what is the how will you calculate the pulmonary vascular resistance? How will you calculate pulmonary vascular resistance? How will you calculate the pulmonary vascular resistance?
CAT study.
CAT study.
No, CAT study. What is the data?
Tell me what parameters you will check.
Tell me the formula.
So mean pulmonary artery pressure minus the left atrial pressure divided by P.
Yes, pulmonary flow. The mean pulmonary artery pressure minus left atrial pressure divided by
QP.
blood flow. Some people even consider that is total pulmonary vascular resistance. What is it?
So what is?
Total pulmonary vascular resistance.
They may not answer, sir.
Mean pulmonary artery pressure?
Minus.
What is total pulmonary vascular resistance? All right, you read about it. I am not going to give you the answer. The pulmonary vascular resistance is calculated by pressure drop divided by pulmonary blood flow. But here there is no pressure drop. You read about the total pulmonary vascular resistance.
And transpulmonary gradient and diastolic pulmonary gradient. These are the questions which will be asked you when it comes to pulmonary hypertension. Pre-capillary, post-capillary, and mixer. Okay, fine. I think we have covered almost all things because Arun has appeared again. And
I think we have covered. I think we had a reasonably good discussion. We have brought in many points, and we could discuss a lot of points, including Epstein's anomaly we have discussed. So I think I'm sure students had a good exposure to various aspects of a cyanotic conjunctival heart disease, especially Eisenmenger syndrome. Okay. Any other point you want to discuss, students?
Sir, I want to ask one question on ECG, sir.
Oh.
So
What is the question?
Sir, on this ECG, sir, how will you differentiate, sir, ECG of a patient with Eisenmenger from tetralogy of Fallot with PS patient, sir? The tetralogy of Fallot patient who's having TORF, sir. They also have same, sir, features. They also have RVH, right axis deviation. They also has this.
And if the patient is having an early transition, if the patient is having a good early transition from V1 to V2, I think I will immediately think that this could be a tetralogy of Fallot.
But sir, this patient is also having V1 to V2 early turn. The Donzelot sign that is seen on EC positive in this patient. They have early transition at V2 from V1 to V2, sir.
No, that is not
there is no sudden transition.
No. Not in this patient.
Basically, in tetralogy of Fallot, usually you will get a very good R wave in V1, suddenly changing to a deep S, and more useful will be V6. V6, the classical deep S is not common in tetralogy of Fallot. That's the one thing, because in tetralogy of Fallot, the fetal pattern is preserved and axis seldom goes beyond 120. Okay. STT changes on right chest leads. The STT, the pressure is always systemic. So the T wave will be normally inverted in V1, V2 in tetralogy of Fallot. The classical transition is tall R in V1, suddenly changing to deep S in V2. That is sudden transition. Whereas in any RVH, from V1, it go to V2, V3, this become problem. And V6 criteria of a very deep S is very unlikely in tetralogy of Fallot, but adult tetralogy of Fallot, when it comes to the age of 65, the changes can be entirely different.
What is the reason for this sudden transition? What is the reason for this sudden transition, the electrocardiogram in a tetralogy of Fallot patient?
Because of this large VSD, this, sir.
Because of the large VSD, unrestricted large VSD? Why there is a sudden transition?
I read it, but I have not remembered, sir.
RVH, sir, RVH.
No, it is because through the VSD you are picking up the LV forces, and
LV,
you can
have RV, sir. RV analysis.
You can have deep S waves, very deep S waves. So the very deep S waves in patients with V2, at the same time V1 showing tall R waves is highly suggestive of tetralogy of Fallot.
I think, sir, we should now close. It is already too late, 9:30.
Yes.
Okay.
Yeah. I think we have had a wonderful session. Thank all the examiners, and I should also thank both the teams and also all those who have joined as delegates for their excellent participation. Special thanks to all the examiners, Manjuran sir, Sudhirma sir, Hilal sir, and for taking this discussion in such an interactive manner, involving both the teams and also answering the questions posed by the delegates. So all of them have benefited immensely. I also thank Dr. Anmesh sir for joining in between. He could not be there for some other reasons. Today's session we had a great talk by Dr. G. Moon on Kaplan-Meier survival curves. I believe all the residents and everyone who joined would have benefited immensely by listening to that important talk on statistics.
One point, I think the student presented very well. The student presented very well.
I think the boy from Srinagar presented the case history very well. He discussed the case also reasonably well. And I think we should congratulate the Srinagar team for bringing out a very interesting case and leading the discussion also.
Thank you, sir.
I also have the same view. He presented well, he answered questions, and I appreciate the answers in the chat box also. We had very good answers in the chat box also. We should appreciate that also.
Yes, okay, I didn't verify the chat box, but once you suggested, I verified some of the answers. I think the students have answered extremely well. Very good.
So both the teams, you are receiving accolades from some of the famous examiners all over the country. So I think that is brilliant work to both the teams. I thank Dr. Hardev from Shere Kashmir, and Dr. Shashank, Dr. Bhusri, Dr. Amish from Negram Shillong for the excellent discussion we had today. And this session goes on thanks to the work done by Chopra sir, Abraham Momin sir, Venu sir, and Harishan sir from HFAI. And now that we've teamed up with the Heart Failure Society of America, we have got this session going on in a greater manner. It's an event that is telecast all over, all across the world now. It's got viewership abroad as well. I must also place my thanks to Corona Sun Pharma and the team Hallmark for all the work done. And we'll get back next month with the next session on November 8th with Shere Kashmir will continue with us, and we'll have another team presenting case as well. So thank you all for staying till late, and good night, and thank you once again.
Thank you. Good night.
Thank you for the invitation. I enjoyed being an examiner, and I thank the organizers for inviting me to today's case presentation as one of the examiners. Thank you.